Please start, sir. We are live.
Hello, good morning, everyone. It's a pleasure to welcome you all for this exciting webinar on hematology up to date. Thank you so much for joining on this Sunday morning. This is done under the Aegis of Cancer Research and Strategic Foundation. With great pleasure, let me have a pleasure to welcome and invite the convener, Dr. Ankur Mittal, consultant hematologist and bone marrow transplant physician at the prestigious Mohanday Oswal Hospital, Ludhiana. So once again, a very good morning to everyone who has joined us. Dr. Ankur Mittal, sir, good morning to you, and the floor is set for your welcome and introduction. Over to you, sir.
Thank you, Mr. Tarun, and good morning, everybody. It's really lovely morning, and I'm happy to engage you all for the today's feast. So again, I welcome you all for the today's academic feast, and today we focus again to learn more and more and to learn relearn regarding the various hematological malignancies and recent advances and treatment options which are available to have better clinical outcomes for our patient. So I'm not wasting much time. So I would like to invite our first speaker. That is Dr. Pawan Kumar Singh. He is a senior consultant and head of the Department of Hemato-Oncology and BMT at Artemis Hospital, Gurgaon. Sir is going to speak on choosing the right venous access in hematological malignancies. That's really sometimes nightmare for our patients to have IVSS. Sir will enlighten new techniques and regarding the picks for our patients. Over to you, sir.
Thank you, Dr. Ankur, for this invite, and I thanks the organizers for arranging this meeting. So, the topic which I am going to discuss today is about venous access devices. So, in oncology, venous access devices are very important, and there are various options, clients and other center venous access. So, the topic is picking up the right VAD, that is the vascular access devices. So if you see the access devices, what we choose in our patients, so we have two options when we can cannulate the peripheral vein or the central ones. So peripheral, we have these options like midlines, prolonged welling catheters, then long PIVC, or the short PIVC, then PICC, CICC, tunnel catheters, and the ports. Now, out of all these options, which to choose for our particular patient? So there are various aspects before we decide on putting a venous access device, which one to choose. So if we see the characteristic of ideal vascular device it should be easy to insert and can be inserted by other trained staffs. Like we have trained staffs who can put USG guided PIC lines. Then it meets the complete venous access needs. So I'll be discussing that in my subsequent slides, and the complications should be minimal. Then when not needed, should be easily removed, and financially also should be okay. So what are the goals? Why do we need peripheral or the central venous access for our patients? So central access is the advantages of that, and the need for it is like monitoring central venous pressure, uh, drawing blood samples, then sometimes vasoactive medications, which are or the vesicants, which can only be given by the central veins, then giving parenteral nutrition, uh, then complex fluids should have stable access, and sometimes in difficult patients like obese patients or thin veins where peripheral cannulation is not possible. Peripheral access, it is usually given for volume resuscitation because it is easy to put, and if patient comes in shock, they need immediate access, so that in that way, peripheral way, cannulation is the most early thing which can be done, giving blood products, sometimes medications and other incompatible, which cannot be given through the same catheters. So, although venous access may seem minor, it can dramatically affect the patient ability to receive appropriate treatment. So, do we need any algorithm? Though there are ASCO guidelines where to and which line to choose from, in particularly in cancer patients. So, yes, there should be an algorithm. So, what are the global guidelines? So, if we see the lack of venous access, it prevents the continuation of chemotherapy. So sometimes because of poor venous access, we are not able to give uh, the dose in timely manner. And 70% of patients receiving irritant or the vesicant chemotherapy, they experience some kind of phlebitis, which is a local reaction. Then 22% of patients receiving irritant or vesicant chemotherapy, they experience extravasation. Even if you take all the precautions, there can be risk of extravasation. So these are the algorithm. Uh, so this is uh, Michigan appropriateness guide for intravenous catheter. So if suppose for a short period of time we need access to peripheral IV cannula or the USG guided peripheral IV cannula, it can be given up to for 5 days. For critically ill patients, midline catheters like IJV or EJV cannulation is done, or acute central venous catheters. So these are given for a short period of time, and once the patient is out of critical illness, it can be removed easily. For cancer patients, these are the options like PICC, tunnel catheters, and ports. So I'll be discussing there. So this is the algorithm again, irritant and vesicant infusions, and based on that, we can decide on which uh, access device to choose. Like PICC is recommended for vesicants and irritant drug institution. Then it is recommended for from day 1 to long term can be given. Then tunnel catheters, usually it is put for patients where we need access device for longer period of time, maybe more than 1 month. And it is PICC is recommended for patients who require frequent phlebotomies and which is independent of type of infusates. For long-term use, all three are possible, like PICC, tunnel catheter, or the ports. And there are various factors which need to be considered, which to be put. So for where frequent phlebotomy for port, usually it is given put for when the chemotherapy or when the usage is for longer period of time. Frequent phlebotomy is not possible with port because we need to put a needle for accessing it. And so what are PICC? So PICC basically it is a peripherally inserted central venous catheter. So it is a thin flexible tube which is put in the peripheral vein and it goes up to the SVC and right atrial junction. So these are the, so we have two options. One is the distal, where the distal valve is placed. So this is close-ended, and other one is the power injectable PICC. So it is named as power PICC line because for giving contrast, rapid bolus infusion is possible with this, and it can sustain that pressure which is given for giving IV contrast. So Groshong PICC line, so it is peripherally inserted central catheter. It is silicone, made of silicone, and it is or the tip is rounded closed with the radio crystal tip, and it is patented 3-position pressure sensitive valve is located at the distant end of the catheter. Does not require flushing or the locking of the device. No clamp is needed. So these are various sizes in which it is available. So this is the valve, how it functions. So negative pressure opens the valve inward and it permits the drawing of blood sample. Positive pressure opens the valve outward and which allows the infusion. At neutral pressure, valve is closed and reducing the risk of air embolism, blood reflux, and clotting. So it is the efficacy access with efficiency of power injection in CCVs. So advantage, as I mentioned, of this power PICC line is that we can give a rapid infusion, which is given for IV contrast in imaging. So these are power injectable catheter. It comes in triple lumen configuration, designed for multiple infusion therapy, power injection capability of 5 ml per second, and can withstand pressure of up to 300 psi. Ability to perform CVP monitoring can be done. It has large lumen, and it is made of polyurethane. So it is fewer in. So the advantage of PICC is that fewer insertion related complications. Like it is USG guided, so risk of hemothorax and pneumothorax is less. Primary malposition also risk is in easily in those patients who are having thrombocytopenia or coagulation disorder, because it is put in peripheral vein, so we can stop the bleeding by just applying the pressure. And even in severely obese patients also it can be put easily, as it is done by the ultrasound guided. So these are the benefits. It demonstrates 81% reduction in catheter-related bloodstream infection. PICC exit site is less prone to contamination, and median time to infection was significantly longer with power pick line at 23 days as compared to 13 days for CVCs. So median dwell time for CVC is usually 5 days, but in power pick line, it can be put easily maintained for longer period of time. It is available in single, double, and triple lumen configuration. So it is recommended for critically ill patients who are having anatomically when the peripheral veins are not easily accessible, which we put blind. So ultrasound guided, it can be easily put, can be put in thrombocytopenic and other patients who are having cardio coagulation disorders, then cardiopulmonary problems or severe malnutrition. So in obese patients also, it can be easily put. High infusion rates can be given through this CVP monitoring, and high pressure injections like contrast radio for imaging, it can be put. And likely to be at higher risk of catheter-related bloodstream infection. So the success mantra for this PICC is think of PICCs whenever you pray. So choosing the right vascular access devices based on expected infusates in treatment journey. What percentage of your patient receive chemotherapy for shorter duration, less than 6 hours, and less than 6 cycle, for longer infusion, maintenance up to 12 months, and chemotherapy plus infusion of monoclonal antibodies and immunotherapies like ADGs. These are the agents which cannot be given through peripheral venous vein, so it has to be given through the central, and PICC is the advantage. Most chemotherapy agents, if we see, they are vesicants or irritant or both. Like these are the vesicant drugs, most of the anthracyclines, vinca, and alkaloids, alkylating agents. Then irritants are mitoxantrone. These are uh, then adiposides, antimetabolites. So these are the drugs which are irritants, and for it is recommended for all these irritant and vesicant drugs to avoid any vascular complications. Central venous access devices are the best, and prevents for these drugs there should not be any extravasation and thrombophlebitis. So in that way, vascular access device is very important. And the other advantage of that is it avoids frequent pricking, phlebotomy, blood sampling is possible. Repeated infusion, including the blood products, can be given through these PICCs. Now, longer indwelling time for PICC reduces the repeated venipunctures, and both ESCO, NHS, MD Anderson, FDA, all these guidelines, they recommend PICC line where we expect the treatment duration to be up to 12 months, and it is PICC is approved for uses up to 12 months and can be cited for treatment lasting a few days to many years, can easily stay in for up to 12 months. And MD Anderson also, dwelling time ranges from 7 to 34 months. So 4 international authorities have endorsed use of PICC for 12 to 34 lines. They are typically utilized for those therapies that have a duration of up to 2 weeks or more. So these catheters have successfully used for extended period of 100 days to greater than 300 days. So most common use 10 to 73 days, more than 300 days are also possible. So these are various studies, global evidence, 269 pick lines put 250 patients, 98% solid tumors, and total catheter days was 55,000. Median was 184 days. So understanding now what are barriers, outcomes, cost comparison, and patient satisfaction. So median catheter indwelling period with PICC, it is 59 days, chemo put 137 days, and the cost comparison was done. So in group one, these are the central venous and the PICC, and these are the chemoports. So if we compare with chemoports, the cost is less for CVC and PICC lines. So the complication rates are also less when it was compared with PICC was compared with CVC or chemoports. So nurses led PICC insertion. Now in our center also, we have trained nurses who are putting these USG guided PIC lines, and there was significantly increased risk of cost when it was put by the radiologist group as compared to the nurses group. So if the institution permits, the trained nurses can insert PICC. It reduced the cost by 60%, insertion rate almost more than 90%, and complication rates were up to 4%. So these were both EGA and position paper statement, USG guided vascular access devices. They recommend the use of ultrasound for putting all these PICC lines. USG guided, it reduces the complications like mechanical infection, thrombosis, and making it more cost effective. So these are the five they have. BD has started this initiative at 5 centers to train the staff in PICC insertion, care, and maintenance. So it clinical expert can also come to your center for on-site training and hand-holding. So finally, to summarize, so central venous access devices recommended for all vesicant and irritant infusates. Also, chemotherapy agents where pH is less than 5 or more than 9, infusates of osmolarity more than 600, like for TPN and blood products. So need to make habit of formally checking and documenting venous status of every patient who will be starting chemotherapy. And every center must provide option for chemoport and PICC. And contrary to common misconception, PICC has been successfully used for both short-term, intermediate term, and for very long-term use as well. And benefits in both continuous and intermittent chemotherapy. So with this, I would like to stop here. Thank you. Any questions? Most welcome.
Thank you, Dr. Pavan, and it was a nice presentation regarding the peripheral venous assess device. I have a question, like at your center, if in case a patient refuses for the PIC or port, so do you have consent to sign the patient? Yes, they have a refusal, or it's a mandatory?
It's not mandatory, but most of the times the patient agree for putting this line because it is easy for the patient also, because then see in our hematology setup patient as compared to other patients, we need frequent sampling like for leukemia and other malignancies where we need the frequent sampling of so this has the Bigline has the advantage that we can take samples, frequent phlebotomy is possible, plus all these vesicants and irritant drugs, so they has to be given. So most of the time we usually don't inquire. Most of the time our patients do agree to go for this PICC line insertion. And as compared to out of all those, see the cost effectiveness. If we see the only access device which is less cost effective is you can put for go for IJV or EJV. But the problem with that is that it is usually discomfort for the patient in putting in line in the neck. So in every aspect, if you see, it is the ease for both the clinician and for the patients as well.
Thanks, sir. Sir, before we proceed further discussion, our panelist and ma'am has already joined. So I would like to welcome ma'am, Dr. Reena Nair. Ma'am doesn't need any words for the introduction, but still, as the duty has been appointed to me, I'm really honored, ma'am, to welcome you. Ma'am is a senior consultant and clinical hematology and head of the department at Medical Oncology, Tata Medical Center, Kolkata. So, ma'am is mentor for me also. Ma'am, I'm giving the charge to you for the further discussion and further invitation. So, over to you, ma'am. Ma'am, you need to unmute.
Thank you so much for this invitation, and happy to be a part of your CME. I believe it's your first CME and it seems to be going all full throttle. So that is really good. And the best thing is starting on time. So I'm really happy to be here. Pavan has given us a really good lecture, and so now he needs no introduction. He is the moderator of the next session. And during the next session, we will be discussing on follicular lymphomas, and especially those follicular lymphomas which have this unmet need of doing something different from the regular BR or rituximab based therapy. And we know that some of the young patients come with a blastoid kind of a follicular lymphoma, or they relapse very early. Then we are left kind of high and dry whether to use the same monoclonal antibody, or we have, and now that we have a different monoclonal antibody, I think it's only just right that we discuss about it, how to access it, what is the experience that people have had on obinutuzumab managing low-grade lymphomas in the context of follicular lymphomas. So the panel discussion is on obinutuzumab-based treatment in follicular lymphomas, and the moderator is none other than Dr. Pavan, who has just taken a lecture for us. And he is the senior consultant at Artemis, which we already know. And I think I will hand over the introduction of the panelists to Pavan. So Pavan, all yours. You can call your panelists and start the discussion.
Hello. Thank you, ma'am. Thank you for the kind introduction. And uh, can I have the slides? Because I think it was supposed to be put by the organizers.
Okay, I will, what I'll do is I will just call the panelists while they get the slides on, and then maybe you can take over. We have
Yes.
Dr. Javed, who's the senior consultant medical oncologist from Srinagar. We have Dr. Deepak Charles, who is from Aster Medicity, Kochi. Of course, we have Ankur in the panel, and we have Dr. Sandeep Kakkar, who's the senior consultant medical oncology from Sohana Hospital, Mohali. And we also have Dr. Padmaja Reddy. She is a consultant hematology, oncology, and bone marrow transplant consultant from Apollo Jubilee, Hyderabad. So we have people from all across. Welcome, Padmaja. Good to see you here. Actually, welcome to all the panelists. So I think, Pavan, you can take over now.
Yes, ma'am. Organizers, can you put the slides?
Support team, can you?
So just a minute, I will share some.
Okay, so follicular lymphoma. If we see, ma'am is there. So ma'am needs no. I think I would request ma'am also, ma'am Reena ma'am, to be a part of this discussion and moderation also. Obviously, we'll be discussing these. So follicular lymphoma, it's a very common type of lymphoma which we come across. In fact, if we see in India, it is the commonest type of non-Hodgkin lymphoma which we come across. Now, we all know that follicular lymphoma grading is there, the histological grading, which decides about the starting on treatment, whether it is grade 1, 2, 3. So grade 3 A and B, everybody knows that the patient need to be started on treatment, and grade 1 follicular lymphoma, usually they are put on wait and watch strategy. There is some means dilemma or about for grade 2, whether to start on treatment or to put them on follow-up, maybe on close follow-up. So now everybody is talking about in follicular lymphoma, in CLL, whether to go for chemoimmunotherapy or to go for oral therapy. So these are the topic of discussion in past 5-6 years, what we are listening and what we are talking about also. So uh, uh, obviously so there are various aspects based on which we decide whether to go for chemoimmunotherapy or to go for uh, uh, this oral agents what we have. So before the slides are there, I would ask Dr. Sandeep is there. So usually, what do you do for when a patient or the histologically patient comes with a diagnosis of a histological diagnosis of follicular lymphoma? So what are the investigations what we usually go for before starting on uh, uh, treatment or wait and watch?
So thank you for the invite, first of all, and really a great pleasure to be here and a part of this meeting. Thank you, Dr. Ankur, as well. So as far as your question is concerned, we all know that apart from the clinical examination, B symptoms, hepatosplenomegaly, we need to confirm the tumor burden of the patient, depending on certain routine blood investigations, markers like LDH, beta-2 microglobulin, and preferably PET-CT scan or CT scan. So accordingly categorize the disease as a high burden disease versus a low burden disease, and accordingly stage the patient as well. Plus, secondly, you need to prognosticate it according to the FLIPI score. So nowadays there has been a revised FLIPI scores. Accordingly, do a proper FLIPI prognostication and accordingly take your decisions forward. Whether to start a patient on treatment, whether he needs, depending on what the situation is.
Okay, thank you, Dr. Sandeep. So we'll start with this slide. So next slide, please. So obinutuzumab, if you see, it is very important in the management of follicular lymphoma. So follicular lymphoma, we all know it is in best as compared to Indian data. So it is follicular lymphoma from India. It is more common as compared to the DLBCL. Next slide. So these are the studies. So incidence rates almost in the range of 10 to 12%. So rituximab, it is important part of so basically targeting CD20 immunotherapy. It is the most important for follicular lymphoma, and it has improved the median PFS and overall survival also as a frontline therapy. So immunochemotherapy induction followed by maintenance with rituximab, it is the standard of care. And despite these advantages, most patients will eventually, ultimately, all of the, because we know that follicular lymphoma is incurable. So next slide. So next question to Dr. Javed. So Dr. Javed, do you usually means what investigation do you do for if you suppose get a diagnosis of follicular lymphoma grade 3A or B? So obviously these patients need treatment. So what investigation do you do for these patients?
Good morning to all. Thank you for inviting. Yes, as Dr. Sandeep also said, that we have to see the first of all stage of the disease bulk, and so we do all the investigation like complete hemogram and LFT, RFT, LDH, and the beta-2 microglobulin to see this risk scoring system where they are falling. They are falling in low risk, intermediate risk, or high risk. So thereby, and also PET-CT to stage in the systemic staging, plus bone marrow in aspiration biopsy. So these things we routinely do to all our patients.
Okay, so nowadays we are seeing that like in Hodgkin lymphoma, PET-CTs, if it is there, so we don't really need to do bone marrow examination. So in follicular lymphoma, so do you do bone marrow test for every patient?
Yes, I do bone marrow in every patient.
We have Dr.
Irrespective of the PET-CT report.
Yeah, so other panelists can comment on that. Dr. Padmaja. Dr. Ankur.
Yes, sir. Means in follicular lymphomas, I think Dr. Padmaja.
Sorry, I think it was on mute. I was talking. So what I was saying, I wouldn't do a bone marrow if the patient is asymptomatic and we decided it's a wait and watch. But as if the patient is going to have treatment, yes, as a staging part, we would do, as it has a prognostic implications.
Yeah, yeah, sir. Even we also do bone marrow aspiration. We at least advise the patient for the bone marrow aspiration and biopsy as a staging workup. And in stage 1, definitely means to stage it and make that decide the treatment plan to in few of the cases.
Okay, so most of the time, yeah, we know that follicular lymphoma, it's very common to have bone marrow involvement. So most of the time, bone marrow is involved in follicular lymphoma. So now coming to the treatment, so the like for all malignancy, ideal is to cure is the goal, but unfortunately, follicular lymphoma, it is we cannot cure. So ultimately, patients are going to get relapse. So next slide. So in last few years, if you see the recent advances in the follicular lymphoma, so initially the rituximab was entered into the treatment regimen for follicular lymphoma treatment. So these are the studies, the gallium data, chemo regimen, and the Prima 10-year update, then update on R-Benda plus R maintenance. So then the relate and it is the final. So ongoing and new studies of chemo-free regimen and research into the predictive and prognostic biomarkers to the surrogate endpoints. Next slide. So we'll start with this case. This is a female 36-year-old smoker, financial analyst. So he came with a CT scan, showed lower abdominal discomfort, for which CT was done, which showed lymphadenopathy, bilateral inguinal and mesenteric nodes, ECOG performance score 0, and there was B symptoms in the form of weight loss, and CBC and differential chemistries were normal, LDH beta 2 microglobulin normal. So the diagnosis of histological diagnosis was follicular lymphoma grade 1 to 2, translocation 14, 18, KI 67, 20%, and bone marrow involvement. Next slide. So, so usually if you see, this is the based on workup, we have already discussed that CT, bone marrow biopsy, these are usually done. And so what staging or the prognostic score which you use? Dr. Deepak?
Sir, I think Dr. Deepak has not joined because of some.
Okay, so Dr. Padmaja can come in. So you do staging for follicular lymphoma, prognostic watch with prognostic score.
So the staging, the standard PET CT and the bone marrow along with the rest of the tests, and we would want to do a flippy 2 score ideally. You've got the age, LDH, beta 2 microglobulin, bone marrow involvement, LDH, and the bulky sites if it's more than 6 centimeters. So it's good to have that, and it's also there are a few things which are not there in the staging prognostic stage. Information is that whether they have got a leukemic phase of a follicular lymphoma, or sometimes you have extra medullary non-nodal diseases. These are kind of unusual presentations. So I think those have to be considered as a high-risk groups. Those are the things I would take into consideration. And when you have got a limited stage disease, we want to see when we are thinking about radiotherapy, whether these nodes are in areas where you don't want to give too much of radiation, where you want to combine chemotherapy with a little bit of a radiation like parotids or lacrimal glands and things, sensitive areas for radiotherapy. But yes, I would do all these prognostication and the standard staging with a PET CT and a bone marrow.
So, Dr. Ankur, so how do you decide about which regimen to start on if you decide for treatment?
Sir, in my practice, I generally follow the JALF criteria for the treatment and indications of the treatment, if the treatment indications are there or not. And once the patient lies as the indication of treatment, then I generally go with the patient characteristics, the biochemical parameters, the age, and the compliance of the patient and their logistics. And then we give the options to the patients. And generally, we either with the BR regimen preferably, and sometimes RCVP or RCHOP, but most probably BR as first line.
So you do you treat differently grade 3A or A and B?
Yeah, sir. In grade 3A or grade 3B, I generally prefer to treat as the DLBCL with RCHOP.
Okay. Dr. Padmaja?
Grade 3B is considered as DLBCL almost for the treatment purpose. 3A, we still think as a follicular lymphoma treatment rather than a DLBCL. Yeah. I mean, the histological staging, what we're talking about, not the radiological staging. When you've got the percentage of blasts are very high, the centroblasts are high histologically. Sometimes even the pathologist may change how they report it as, whether they put it as a transformed and things.
Okay. So
I think very important points put here. Grade 3B, very closely to be while choosing the regimen, because definitely these are the candidates who are at risk of early progression. So I think best regimen should be forward in such cases.
Single line dose कौन सी होती है?
Dr. Javed?
Yeah, definitely. Grade 3B treat as DLBCL. So R-CHOP will be the best regimen for that. But for rest of the stages and grade 3 or down, we use BR regimen as of now.
Okay. So, and the anti-CD20 rituximab is the preferred. Anybody uses obinutuzumab as a first-line therapy?
So it depends on, I think finances are an important concern in Indian setting. So preferably if there is a choice, keeping apart the finances, so definitely obinutuzumab scores over rituximab in some of the points as we move on, and we have seen in the clinical data as well, where I think the risk of progression in the first 2 years, which has been taken as a surrogate of PFS nowadays, so it is less with obinutuzumab. So definitely finances are not a concern. You can use obinutuzumab over. I'm more inclined towards using Gazyva over rituximab.
Okay. So next slide. So yes, so this is basically based on tumor burden, as Dr. Ankur has mentioned, the GLF criteria and the BNL-I criteria. So if high tumor burden, these are the criteria. So these are considered to have poor prognosis. So usually they are treated with chemoimmunotherapy, and if the patients are fit. So these are the criteria based GLF criteria. It is based on lymph node size, spleen size, and serum markers like elevated LDH or beta-2 microglobulin, then cytopenias and the clinical presentations, which in the form of B symptoms. Next slide. So we have already discussed how to risk stratify, as Dr. Ankur has already mentioned that prognostic markers, these are help to identify follicular lymphoma at risk of early progression. So how do we identify before starting on treatment? And these are the baseline characteristics. And during treatment, identify opportunities to adjust and treatment regimen. So early treatment outcomes and the combination of markers. Next slide. So now, Dr. Padmaja, do you routinely do interim imaging or the interim analysis to look for the response to treatment?
I do. Despite having said all these flippy scores, one of the best things to know the patient is going to have a good PFS or not is somebody who's gone into a complete response, end of 3 cycles, you know that they're, whatever irrespective of the things that you're going to do well. I still think that would be a very validated approach. People may differ. So I would. If suppose that patient has not had a complete remission, very less PR, less than 50%, then you do have to think about changing the treatment at that time rather than waiting for 6 cycles. So yes, I would.
And usually how many cycles do you decide to start to give?
So total of 6 cycles, the midway through end of 3 cycles I do. I know people do end of 4. But NHS practice has been at the end of 3, so that's how I'm used to doing it, end of 3. Yeah.
Okay.
We're talking about a stage 3-4 disease where we're decided that it's a systemic treatment and plan for 6 followed by maintenance. That's where we would do middle of, before we start the 4th one.
Okay, so we have already discussed about the FLIPI score. It is based on Ann Arbor staging, age, hemoglobin, and number of nodal site period, serum LDH. So this is the Kaplan-Meier curve mentioning the low risk, intermediate, and high risk disease. So it is very important and validated marker for prediction of overall survival and progression-free survival. Next slide. So it is validated and prognostic tool which predict the for the PFS. Next slide. So there is another prognostic index which is the Prima PI is a new model. So which has included two parameters, mainly the bone marrow involvement and the beta 2 microglobulin. So beta 2 microglobulin, if it is more than 3 or less than 3, so more than 3 it is considered as high risk, and then with bone marrow involvement, yes, intermediate risk, not involved, so it is low risk. Next slide. So do we need better prognostic tools? So like baseline PET scan, then end of induction PET scan, and combined PET and other tools like MRD assessment, circulating free DNA. So these are the various other tools. So these are the studies like we were discussing about end of treatment, the progression. So those who have negative PET after induction, and then if the PFS rates are more for those patients who have negative PET after the induction cycle, and the better PFS, if we see 63% versus 23%. So suppose if there is after end of treatment, like end of 6 cycles, if there is PET is not negative. So what do you do, Dr. Ankur? In that situation, what do you do?
Sir, if the end of the treatment, the PET is not negative, the localized disease is there, we can ask for the radiation department for the localized radiation. And means depending on the, means is it a progressive disease or it's a partial response is there. So first we have to look on the new nodal findings are there or not. And we can have, if the SUV uptake is on the rising trend, we can have a repeat biopsy to see is it the same disease or it has been transformed to DLBCL or something like that. So these all parameters we have to look about.
Dr. Sandeep?
Yeah, I mean, if on day one it would have been a high volume disease with bulky sites, IFRT or INRT is a valid option. And definitely before proceeding, as Dr. Ankur said, I agree, you should always rule out the progression in terms of a transformed DLBCL if it is a increase in the size or the SUV uptake of the nodes.
No, and if it is not localized, if it is generalized disease is still present, and the response is not that optimal.
So again,
can I
Yes,
make a
Dr.
point?
So again, I would say if there is a residual disease and the burden of the disease is significant, and you have various nodal sites that are involved, so definitely even if the PET shows, we confirm it that there is a residual tumor present with FNA or a biopsy, and later on move to the second line of treatment and move to the other options like autologous bone marrow transplant. So definitely you have to treat in such a way that this is a kind of patient who is at risk of an early progression despite being on treatment for say 6 cycles or 8 cycles and has not responded optimally.
Maybe I would like to have comment of Dr. Reena ma'am on this situation. Ma'am, we sometimes we come across this kind of situation when we give 6 cycles of RCVP or RCHOP or maybe BR, and still we have the persistent disease. Though it has responded, but still some disease is there. Some people used to say, okay, give 2 more cycles and then reassess the disease and then decide about, because if the PET is negative, we usually put them on maintenance. So what to do, ma'am, in this kind of situation, if suppose still the response is there, but it is suboptimal response? So whether to shift it to maybe give salvage or shift to other regimen or to give 2 more cycles. So what should be done for in this kind of situation?
So if one is you get an idea that there is slow response if you've done an interim assessment and an end of treatment assessment, and continuously if the disease is coming down and you have something which is a very good partial response, though there is no definition of very good partial response, but like you are saying, a small disease left in one area or a few small nodes left in another area which are showing FDG uptake, which is not very high, then there is enough evidence to say that if we continue them on maintenance, at least 15 to 20% of the patients will go into a complete response during their maintenance and do reasonably well. So I would not really make too many changes if the patient is doing well, continuously improving, has no symptoms, and can be considered for maintenance, especially in any case after RCHOP and RCVP, you will give maintenance. It's only after BR that we kind of take a decision whether if it is complete response, do we really need to give maintenance to these patients. So there I would, just continue the treatment. If there's significant amount of disease left, then it's always a good idea to biopsy that area to see if there is any transformation and then follow the very aggressive path. And which means then you go ahead with your salvage therapy and an auto transplant. What do you do with a person who has still follicular grade 1 disease left in the node, which is not a very high SUV, neither is it a high grade on PETs on the biopsy? In those patients, I don't know, we are always worried about this not good response or relapsing early within 24 months. And those are the patients in whom we need to be more aggressive because we know these fellows don't have a great 5-year survival. And so perhaps changing the regimen at this point of time, trying to put them into remission. And then we have so many other options available now, like changing the immunotherapy, changing the chemotherapy, and then we have newer bites which are coming in. So we will have many options. Regarding auto transplant in these patients, I'm not really sure if it is the best way to go. If at all it's a young patient and you are thinking of an aggressive outcome and an aggressive treatment, then perhaps an allogenic transplant in a young patient with follicular lymphoma who has not responded is a better way to look at, because you do need some whatever we call as the lymphoma effect of the allogenic transplant rather than just the high dose chemotherapy, because we know these are not chemosensitive patients.
Okay, thank you, ma'am. Next slide. So now this was the study. So rituximab versus waitful watching in asymptomatic follicular lymphoma. So we have discussed this thing whether to put them on waitful strategy or to give rituximab every 4 weeks. So this was the study which conducted, and it was a randomized phase 3 study. So basically 3-arm study, and after that follow-up was done. So waitful watching and rituximab weekly for 4 weeks given in one group, and after that, and the other group after 4 weeks, then they put them on maintenance every 2 months for 2 years. Next slide. So in this study, the PFS was rituximab versus watchful waiting in asymptomatic follicular lymphoma. Overall survival more or less same, and patient who had maintenance rituximab versus waitful watching, the PFS was better in patients with who were given rituximab in the as a induction and then maintenance arm. Next slide. So staging workup, we had discussed with this PET-CT. So abdominal, bulky disease involvement, mesenteric, paraortic, common iliac, and these are Ann Arbor stage was 4, FLIPI3, high risk disease. Next slide. So treatment choices for these patients. Next slide. So again. So this question is to Dr. Padmaja. So how do you decide about what treatment regimen to choose for your particular patient? Like in this patient, it is, go back to previous slide.
So with respect to the study you've just shown about a wait and watch, oh, this patient, yeah, 36-year-old financier who has got a stage 3 disease.
Yes.
The questions are, this patient has got symptomatic stage 3, at least. Bone marrow, is it involved? I've not seen.
Yeah, bone marrow is involved.
He has got a stage 4 disease and he's symptomatic, with the B symptoms. He definitely needs treatment. The question is, he's a financial, so money is not an issue. We could talk about upfront treatments, whether it's BR versus BO, obinutuzumab with a bendamustine, and maintenance strategies. So if the patient has got no problems with the finances, then certainly I would prefer a BO regime. There is no wait and watch here. Certainly patient needs a treatment, and we would certainly discuss about this patient. She's very young. She is going to see relapses. Even whatever we do, it is going to have a longer PFS. And I think at the first instance, talking to them, giving the expectations is very important for a younger patients, as they may not actually follow up for a long term with the same centers as people keep traveling. It's knowing about their disease type, that it's incurable, that it's going to come back. But what we're trying to do is get it into complete remission and then get a longer PFS on the maintenance strategy, and make sure no other comorbidities, and her hypertension is not going to be a greater issue here. So I think that's at the outset. And we would talk about how the PFSs will change with the maintenance, and whether long-term maintenance, would it have immunosuppressive effects, whether it's going to be increased risk of infections, all that. It is very minimal. The toxicity is minimal on the maintenance as well, especially for a younger patient. So, okay. And the patient expectations, again, we spoke about the length of infusions. We know from the studies that even if we use obinutuzumab in the first cycle, it takes longer. The reactions are higher, but many of them tolerate well, and they have a less amount of toxicities, is less than grade 2. And you can do in 90 minutes infusion in the cycle 2 onwards. Just the cycle 1, you have 3 doses, and the cycle 2 onwards, it's once a month dose, and it's 90 minutes. So obinutuzumab, the big problem is the duration of infusions and the reactions. But a large population do not have, if you give a proper, preventative measures and take the infusion slower.
So, Dr.
Sandeep, can I add something here? If it's a young patient and somebody who has a very large mass, despite the fact that whatever you have biopsied has come as grade 1 and 2, and you have a normal LDH and a normal beta 2 microglobulin, I always feel that, these are the patients in whom we should have a CT scan done and look at the SUV in this area. And if the SUV is very high, which in my practice I see quite often, then it is a good idea to have another biopsy from the highest SUV, because some of them actually are already transforming at the time when they have come. And that will also help you to choose your regimen, because if there is transformation anywhere, you will go with an anthracycline-based regimen.
Yeah, absolutely true. I've not paid attention to 22 centimeters. I was reading at 2.2 centimeters. Yeah, absolutely. If you've got a larger mass, I completely agree. So yeah, we have to biopsy that high SUV area and to rule out transformation. Yeah.
Now, so this in my question again, ma'am. So, like suppose we have done the biopsy and we already have the diagnosis of follicular lymphoma, and we do it. So obviously PET scan is usually, most of the time it is done after the diagnosis of lymphoma is made. So because usually we do biopsy from peripheral nodes, maybe axillary or cervical or inguinal. And if suppose we get a high SUV, so how to convince the patient? It will be difficult to go a re-biopsy of, suppose abdominal node comes as very high SUV.
I think the treatment is going to change. So we have to give that option, because the treatment would change if it was DLBCL. It's a similar vice versa. Suppose this patient has had a scan and we have biopsied this 22 centimeter mass with a high SUV, and you've got other masses, and this biopsy came back as I have got exactly a similar patient whom we biopsied that turned out to be a high-grade lymphoma with possible transformation changes, but her fish came back as 1418. So that some parts she has got a follicular lymphoma at the time of diagnosis, and certain areas have got a transformed disease. So we would convince this patient to have a rebiopsy at that site to know.
So I will only say convincing patients is a little bit of, art of counseling. And if we sit down and speak to them, and by and large, these are all very highly educated people, and give them the option to go to their Google doctor also, they will come back and say, yes, if the treatment needs to be changed and it is with a, intent that I get the best outcome, they will go ahead with what we say.
And I think raising that expectations, 22 centimeter mass, we know that it's not going to go down, it's going to have a residual lesions at the end of treatment or midway through. Giving that expectation upfront is also important, just to have that kind of a thought.
Yeah. Go back to the previous slide where we were already on. Yes. So we have already discussed about this in advanced stage follicular lymphoma. So for low tumor burden, we have option of either observation or rituximab monotherapy and giving maintenance. For high tumor burden, most of the people we can select on with high based on GLF criteria whether to put on anthracycline or not. And then we have option of R-CHOP, R-bendamustine, or R-CBP, and then rituximab maintenance. So in our practice, Dr. Ankur, how do you decide, or we usually give the option of obinutuzumab as a frontline treatment?
Yes, sir. I generally give the option that we have two molecules available with us, that is rituximab and gemtuzumab oxazomycin, and I generally tell them that having Gazyva as a treatment option, these are the benefits which we get, that as has been discussed by Dr. Sandeep, like 2 years, the chances of relapse are less as compared to rituximab plus bendamustine. But at the same time, we discuss the cost effectiveness also with the patients, and they opt out of these two molecules, whichever they want to go ahead.
Yeah, but nowadays, yeah, because if we obinutuzumab also, if with the patient as a program, it is not very costly when we compare it with rituximab. So can be given the option of
Yes.
next slide. So these are the studies where they have compared rituximab. So do we see a clear advantage of obinutuzumab as compared to rituximab based treatment? Dr. Padmaja, Dr. Sandeep.
In clinical practice, if you ask me, yes, theoretically, if we look through the literature, definitely it's showing some advantage. But in real life practice, have I used patients upfront with the BO regime? No. But have I used obinutuzumab? Yes, I've used in 6 patients. So in different indications, people who have not responded to rituximab-based regime, I've used obinutuzumab and they've responded. There was somebody who had used 4 doses of rituximab. For a time period later, they had a relapse, and we've used a BO regime and gone into remission and completely going on a maintenance and been PFS now about 4 years. So there are patients, it is slightly off the radar, that I've used in combination with the salvage because we had no other option in patients with the relapsed refractory DLBCLs. And I've had good responses, and I was able to take them through transplant, and they've been in PFS for 2 years. This is from the studies, but this is my experience, which I've used in multiple occasions, obinutuzumab. But upfront, though I spoke, many patients did not agree, but I don't push. It's how we counsel, because I strongly believe it's a it's a disease which has got a long-term survival, even if you use our chemotherapy. So unless you've got a bad prognostic indicators, that's the time I stress upon and then counsel. And I think how we counsel patients, it also makes a difference how they would make a decision. So even if we give a rituximab-based chemotherapy, we've got a good PFS, close to about 4 years, even in the, just the rituximab era. So to counsel somebody for BEVO straight off in standard risk, I wouldn't push them, though I would give them the option.
Okay, next slide.
Yeah.
So yeah, so basically, so these are the points which we need to discuss, which chemo partner to combine with chemotherapy, which anti-CD20 we need to see. So there are various factors, age, comorbidities, and so these are the chemotherapy parameters which we need to see. Then which anti-CD20, whether to go for ipilimumab or rituximab. So we have to see that these factors, risk, efficacy, safety, parameter. So, Dr. Sandeep, so do you give the option of obinutuzumab to your patient, Dr. Ankur, or maybe a panelist can comment on that?
So I think in my practice, I do give them an option of rituximab versus obinutuzumab, and fortunately or unfortunately, I have used more rituximab. Everybody has used more rituximab over obinutuzumab, and I've gained experience over the past few years with obinutuzumab as we gain more and more empaneled patient and use them in various indications like CLL or follicular lymphomas. And yes, definitely there has been a difference where we had used earlier rituximab and later on obinutuzumab in the relapse refractory setting. So it has made an impact in a real world setting and a clinical practice. So another important point regarding this patient, she is a young lady with a very high burden of disease, 22 centimeter mass, has already stated that even though we concentrate more on selecting a anti-CD20, but yes, the choice of chemotherapy backbone is equally more important. The patient who's having such a high-grade disease and a high burden disease. So choice versus bendamustine versus CHOP, my choice in this patient would be considering CHOP. And as earlier panelists have stated, we do face a difficulty in counseling the patients for a repeat biopsy and a repeat IHC as well. So that would take an additional, I think, 15 to 20 days in starting. There is some sort of delay in the patient's treatment as well. So at times in, I think, day-to-day clinical practice, it becomes difficult to counsel the patient, and when in a way they are more keen for treatment when they come to know that it's a high grade or a high burden disease. So these are the kind of factors we definitely face in a day-to-day practice, and particularly in a young patient with high burden disease, my choice goes with using anthracyclines first. So, and definitely considering the current scenario, I would use obinutuzumab over rituximab if finances are not a concern.
Dr. Javed?
Yeah, we have seen in our clinical practice that having high burden of disease, sometimes some may relapse early, some don't relapse, even though you're giving the same kind of treatment to both the groups of the patients. We don't have a proper tool as of now yet available clinically that we can say that this patient is definitely going to relapse at what we are saying as POD 24 months. But as far as the obinutuzumab is concerned, yes, it has clinical trials shown that it has a good PFS, and that can be converted into overall survival benefit as well. And I have used in CLL, I have not used in first-line follicular lymphoma, owing to its high cost. Even though now company has given patient assistance program, still it is very, very high than rituximab. So in CLL, I have an experience, but in the follicular first line, I don't have in follicular relapse setting, I have an experience of using obinutuzumab.
And okay, so next slide.
Yeah, Dr. Dhawan, actually, I have also
Yeah, Dr. Dhawan, please.
obinutuzumab in CLL patients, not in follicular lymphoma patients, and it's about 6 to 7 patients, and 3 are relapsed refractory rituximab. And having this obinutuzumab as second line, the results are good, and MRD rate negatives rates are high. Uh, Sir, at this moment, I want an opinion from ma'am also regarding the considering the size as 22 centimeter. Will we include anthracyclines as first line instead of BR, even though it is follicular grade 1 or 2?
Yeah, my own for young patients, I am somehow much more convinced that anthracyclines is a better drug. They tolerate it also better. And so, like, even if they don't consent for a rebiopsy, I would go with anthracyclines in these patients.
Like,
And there is another aspect with bendamustine, the higher rates of second malignancies. So, do you come across, have you seen any cases with the usage of bendamustine?
We have now the other advantage of BR regimen is now we are seeing some patients who have crossed 10 years of their therapy. So the question of operational cure in these patients has now come up. So there are patients who are doing really well. And we all know that one malignancy potentiates to the other malignancy. So those who are going to actually live much longer than the earlier anticipated 4-year PFS and maybe 7 years or 10 years overall survival are now going to live their normal lifespan. So we may see extra malignancies, second malignancies for certain. When I look at our entire cohort, we do have now head and neck, cervical, and a couple of other GI malignancies, pancreatic and colon. But there are so few that to say that the bendamustine has created these is still too early for our own data. If you look at data from outside, yes, second malignancies are known and they are being well documented outside. And I think it is time for us to put all these patients who have crossed 10 years of therapy into a common pool and see if we are actually seeing more second malignancies in our patients.
Yes, ma'am. Thank you, ma'am, for this nice comment. Actually, yes. So if we collate all these data, then it's better to have our own experience of using this. Next slide. So this was the study NHL1 2003 study. So it compared R-Benda versus R-CHOP in previously a newly diagnosed non-Hodgkin lymphoma or mantle cell lymphoma. So these were the various histologies, stage 3-4 follicular lymphoma, Waldenström, mantle cell, SLL, and marginal zone lymphoma. So this was 10-year update, randomized to 1:1 ratio, 6 cycles of R-CHOP and R-Benda. Next slide. So in this, the 10-year, the time to next treatment, which was used as a surrogate for PFS, it was better with R-Benda as compared to R-CHOP. Next slide. So go back to previous slide. Yes. So in this, if we see in a longer follow-up period, so it in this basically 10-year update, it showed the superiority of R-Benda over R-CHOP for newly diagnosed patient in terms of PFS. So here or maybe as ma'am was saying that as a follow-up for our set of patients, we can, if we put that data, and ma'am's own experience is showing that it's near operational cure for these patients, what we can say, because they're 10 years at disease, patient is not having any progression of disease. So it has clearly R-Benda is having benefit over R-CHOP. So again, based on this, ma'am, your comment on this study.
So, this we know for certain that maintenance is an important part of low-grade lymphomas if you have treated them with R-CHOP. So actually, if we have the younger patients with R-CHOP and we definitely give them maintenance, I would like to see a comparison with BR, which we don't have at the moment. BR in indolent non-Hodgkin's lymphoma, definitely, as far as responses, progression-free survival, overall survival, and the best is the toxicity. The toxicity is far less with BR than your R-CHOP. Immediate toxicity, especially for a young female working like this, and in the long term also when we look at the cardiac outputs of these patients. So any day, if it is a proven indolent non-Hodgkin's lymphoma, I will go with arbendamustine. It is a well-defined treatment, and we are now seeing patients who have kind of plateaued after 10 years. And we begin to believe that some of our patients may actually get cured with this regimen.
Maybe Dr. Padmaja, Dr. Ankur.
I think we've nailed it. There's nothing more to add. Absolutely. What Reena ma'am said.
Yeah.
Yeah.
Dr. Ankur, based on all these data, so would you means prefer to go for R-CHOP or R-Benda for this?
Oh, for this particular patient, yes, R-CHOP, as it's too bulky disease. You know, if we have not biopsied it, we would go with R-CHOP and then see. If we did biopsy, then still it feels like we should add anthracycline given the bulk of the disease.
And we must give maintenance to this patient, even if she's in complete metabolic response after the third cycle. At the end of therapy, repeat durable response, but plus maintenance is important because that by itself will improve the PFS further, and it reduces the 10-year chance of transformation if maintenance has been given to patients post R-CHOP. So unlike the trial, which did only the induction, maintenance will be extremely important in this patient.
Okay. Yes.
And the young
Next slide.
lady, probably we would have discussed the fertility issues, and because it's incurable disease, one have to think about fertility preservation in the sense over collection and freezing if she has not completed a family.
Yeah. Next slide. Next slide.
Sometimes I do think that in DLBCL patients, we are just giving R-CHOP and we are not going for R maintenance. And follicular lymphoma, and we all know that in one or another day, they will convert to DLBCL. But in follicular lymphomas, giving R-CHOP and then followed by R maintenance. So should that R maintenance will be there in DLBCLs also? Should we need to have it over there or not?
So in DLBCL, there is enough data actually which says that they have randomized trials, and the randomized trials have actually not shown any improvement in the outcomes if you have given rituximab in the induction. So the maintenance doesn't add anything except maybe cost and the risk of infections. If you, in the very early times when, you know, there were many patients who had not got rituximab in the induction, there was a group of patients who had taken their CHOP, and when rituximab came up and began to show some promise, they were given rituximab maintenance. So if you didn't get rituximab in induction with CHOP and you were given maintenance, you did almost as well as those who were given maintenance therapy post in DLBC. Sorry, those who were not given in DLBCL. So I will just clarify what I have said. For DLBCL, there is no evidence that adding rituximab maintenance makes a difference unless they did not get rituximab in the induction for whatever reason. Now, I don't think there's any patient like that who doesn't get rituximab in the induction. There is only one, I think, trial from the British group, which has shown that maintenance may have a benefit in the male cohort of patients. So it doesn't benefit the females, it benefits the male patients. And so there may be some reason to give rituximab maintenance to DLBCL male patients, but nobody else has proven. The real world data doesn't prove it. And they all felt that perhaps there was, you know, some kind of rituximab, let's say, the pharmacokinetics of rituximab in the men, which was slightly different, but nobody has really proven that. It remains as a hypothesis. So the present recommendation will be no rituximab maintenance to DLBCL patients.
Yeah. So as ma'am was discussing about the rituximab maintenance, next slide. So the study, this was the BRIGHT study, which considered about the role of maintenance. So they have compared induction with R-Benda versus R-CBP and R-CHOP, and then they were given maintenance. Next slide, and longer follow-up study in again in indolent and mantle cell lymphoma. Next slide. Next slide. Yeah, so this post-hoc rituximab maintenance, it actually markedly prolonged the duration of response in follicular lymphoma after first-line R-Benda. So this is the study which is showing maintenance after R-Benda and no maintenance. So there was clear survival benefit and progression-free survival also benefit when we give rituximab. So at this point, we have already discussed, and ma'am has already said that in indolent lymphoma, yes, rituximab or obinutuzumab, so anti-CD20 maintenance therapy is very important. I think most of us do agree that maintenance therapy to be given. Dr. Ankur, Dr. Javed, your comment on that?
Yes, R maintenance or G maintenance, if we have given G earlier, that is the practice for indolent lymphomas. Everybody gives now.
Yes, sir, I do agree. Armin is one which should be considered in indolent lymphomas.
So I will just take one more minute on this present slide. Bendamustine rituximab is a combination where if you don't want to give maintenance, you have enough reasons. And I especially have a long discussion with older patients because those are the patients in whom I expect more complications with 2-year rituximab maintenance. And if you see, there is really no overall survival benefit for these patients. In young patients, however, we know that they're going to go for a long haul and we don't want the transformation to happen. And definitely the maintenance reduces the risk of transformation at 10 years. So bendamustine rituximab is a regimen where I sometimes give no maintenance to the older patients, the very sick patients, or the very, I won't say sick patients, very fragile patients. And for younger patients, of course, but after, if I've given R-CHOP, I give maintenance to everybody because it makes a lot of difference to them.
Yeah, this is very important point what ma'am has mentioned about the maintenance, particularly when we have given induction with our Benda. So yes, ma'am, I also agree with this point that yes, if we are giving for some reason, if we are not able to give rituximab maintenance for old frail patients, and particularly in our set of scenario or our country where the infection rates are so high, we do get hepatitis B reactivation after rituximab and other kind of infection, tuberculosis and all those infections. So these are also important points which needs to be considered. So next slide. Yeah, so this is the relevance study of rituximab plus lenalidomide. There was some 3-4 years back, a paper was there, R2 CHOP in DLBCL. So in this study, so rituximab plus lenalidomide versus rituximab chemo followed by R maintenance for follicular lymphoma. So treatment was based as per of the GLF guidelines. So they were randomized into 6-month period of R2, then R chemo, R BR, R CBP, or R CHOP, and then rituximab maintenance. So total period, treatment period 1 for 6 months, and then for period 2, 1 year, and then rituximab maintenance for 1 year. It was given. Next slide. So again, in this, the CR or the this so did not demonstrate the superiority over R chemo for either of the co-primary endpoints, which are the CR or CR unclassified. So if we next slide. So this is about NTCD. So for some reason, go back previous slide. So for some reason, like for some old, as in the algorithm also, we saw that some patient where they are not fit for anthracycline based chemotherapy or even R bendamustine. So there is option of R2 rituximab plus lenalidomide patient. Obviously not for the bulky disease patients, but it will be a kind of palliative type of treatment. Ma'am, your comment on this?
So upfront, I agree. Now the trial has also proven that it is not the best line. And the other thing is, it is not really so easy to give lenalidomide 20 milligrams daily for 21 days. I mean, all of us have seen with myeloma also how many
Yes.
patients are actually able to tolerate the 20 milligrams, and this is for a reasonably long period of time. So as a second line, it is good, especially in very elderly patients who want outpatient treatments, who don't need to come too often to the hospital. I would definitely think if they don't have very high volume disease and they are in reasonably good shape and they have relapsed or need their second treatment a long time after their first line treatment, I do consider R square. But remember, it is, the thought was it will be easy to give, but it is not that easy. And most patients actually come down to 10 milligrams or they have terrible skin allergies. So it is not an easy treatment, though it looks easy when you say R square.
Yeah. Okay. Thank you, ma'am. Next slide. So we'll just quickly go through this obinutuzumab. It's a type 2 anti-CD20 monoclonal antibodies and approved as a frontline therapy also in follicular lymphoma. And next slide. So the gallium study. So it compared the obinutuzumab given as per the schedule plus CHOP, CVP or bendamustine and the same. So CHOP, CVP, bendamustine. This was compared plus rituximab or obinutuzumab. The end of induction CRPR. So these are the primary endpoint was the PFS. The secondary endpoint was PFS, overall survival, EFS, and disease-free survival. Next slide. So in this study, so these are the baseline characteristics. FLIPI score high. So almost 42% of patients had high FLIPI scores. Next slide. So this study, if we see the PFS was improved with the G versus R chemo in earlier analysis, and it was maintained up to for the follow-up of 5 years. Next slide. So again, this also. Next slide. And again, PFS was favorable with the G versus R chemo across majority of in subgroup analysis also. Next slide. So for intermediate risk, next slide. Next slide. We'll just quickly go through this slide. So PET response at end of induction was associated with improved PFS, and this was CMR. So there were more number of CMR as compared in the so CMR. Those patients who have achieved CMR, they have better long-term survival. Next slide, and the overall and progression-free survival. And next slide. So this study, in this study, the Gazyva led to more number of patients going into CMR as compared to rituximab-based treatment. Next slide. Next slide. Next slide. So, but the overall survival, if you see, it is almost comparable to both obinutuzumab or rituximab. Next slide. Safety wise, so we all know that infusion related toxicities, and they are more common with obinutuzumab as compared to rituximab. Next slide. But they are usually well tolerated and well managed with this. So there was this is So, ma'am, your comment on this study about use of because we are talking about obinutuzumab as a frontline treatment for follicular lymphoma.
So, like all your panelists said that we have all used it in the relapse setting. And it's mainly the cost constraints. So I too have used it only in the relapse setting. I have never used it in the upfront, and I belong to a middle. What should I say? If we have the rich hospitals and the institutes and the regional medical colleges, I belong to something in between, and all our patients will not be able to afford it. The other thing is, if a substantial number of patients needed it, which means we are looking at how many follicular lymphomas will have a POD of less than 24 months in your practice, it would be somewhere around 10%, at max 20%. It's not 80% of the patients would be in that category. And so if it is finding those 20%, it is finding some rare patients. Presently, there is no way that we can upfront make out who are those 20% or 10% who are not going to have a good PFS. And so unless the PET, TMT, or MTV, or the circulating DNA becomes a substantial tool in helping us upfront decide that these are definitely the fellows who are going to have a POD of less than 24. And so for those, maybe we need to do something more than what we are doing, because they have a terrible outcome at 5 years. For the rest, 80%, we will just be over treating them with something that is so standard, so easily available, and so reasonable. So sometimes it's the logistics that makes you take the decisions rather than what is the latest in the literature, even if it is a randomized trial. Suppose the overall survival was different, I'm sure we would have found a way to start thinking of a change. But as long as the OS is not different in an indolent lymphoma, I don't think we should, as a scientific community, push for something which is so expensive. And of course, counseling is an art, so you can always counsel that this is the best. But you have to look at, a patient of indolent lymphoma has a second chance, third chance, fourth. Some are now on the fifth treatment. And will we utilize all the funds upfront so that they have no money for the second line, is something that all of us have to think in our practice.
Thank you, ma'am. Thank you for your comment. And this is a study short duration versus long duration infusion. So it also compared.
Hello, sir. Sir, kindly conclude your talk in 2 minutes, sir.
Yeah, sure. Thank you. So next slide. So even shorter duration of infusion can be given with less not much significant infusion reaction. So what should be the preferred chemotherapy backbone with obinutuzumab? Ma'am had already discussed that bendamustine, CHOP, and CVP. If we see the Kaplan-Meier estimates, so bendamustine combination is better, as we have seen with the rituximab combination. So similarly, in this G benda versus R benda, so again PFS. So it is not directly compared with that, but we can say that yes, bendamustine combination is better as compared to other regimens like CHOP or CVP. Obviously, for bulky disease and younger patient, and where we don't want to give maintenance for some reason, then bendamustine would be the preferred regimen. Next slide. So these are the chemotherapy backbone, various backbone combination with obinutuzumab. Next slide. So I think we would maintenance therapy. We have already discussed that maintenance. Yes, it is needed unless we are going for rituximab, this bendamustine based chemo backbone, where we can still omit maintenance therapy. But usually, most of the time, it is preferable for younger patients where there is no contraindication. We should give a 2-year maintenance to all the indolent lymphomas, the follicular lymphoma. So I think I would like to stop here. Thank you. We'll not go for the case 2. So it was nice discussion, and it was nice having comments by Dr. Reena ma'am, and it's always means we always happy to learn and to listen from ma'am. Thank you. And with this, I would like to end here and the closing comment by Dr. Reena ma'am.
Ma'am, before to end the session, I have a one query that are we doing molecular studies for the lymphomas at Tata? Means have we started it or not yet? That M7 classification or something like that.
So we still stick to Flippy. We haven't yet gone into M7, and we have a large database, and we are all looking into what is the outcomes of follicular lymphoma. So in a short while from now, we should have the outcomes. I think I've enjoyed the discussion very much, so much to learn, and so nice to see so many new people into the field. I won't take any more time. Let's carry on. We are absolutely bang on time. So thank you, Ankur, for this invitation, and thank you, Pavan, for a great discussion, and to all the panelists who were there on this particular CM.
And I think Dr. Rajiv has one query. Ma'am, Dr. Rajiv Gupta is a professor and head consultant at SGRD Hospital. I think he has some query. His raised hand. Dr. Rajiv? Maybe. Right, ma'am. So, shall we switch to the next session? If you allow us.
Yeah, go ahead. You're bang on time.
Thank you, ma'am, and thank you, Dr. Pavan, and all the panelists, Dr. Javed, Dr. Sandeep, and Dr. Padmaja. Ma'am has already paid thanks to everybody, and Dr. Pavan too. So we are going to the next session. So the next session is by Dr. Rajiv Gupta. He's a professor and consultant at SGRD Hospital, Navam, sir. He will be discussing on DLBCL frontline therapy beyond the RCHOP. Over to you, sir.
Thank you. Is I audible?
Yeah, sir, you are.
Yeah. Kindly show the slides. So good morning to all. First of all, I'm thanking the organizers and Ankur in special who provided me this opportunity to discuss this important topic of DLBCL. As we have been treating DLBCL as a medical oncologist and pathologist, and we are sticking to the old gold standard RCHOP. So I'm here to deliberate what next can be done, whether we can achieve a better CR, better overall survival by the permutation combinations of new drugs. So it's the most common type of the lymphoma, usually symptomatic. It's majority nodal, sometimes extranodal. And we all know it is phenotypically as well as genetically heterogeneous disease. As we all know that initially CLL used to be looking like same disease, but later on by genetic analysis, we came to know that it's an heterogeneous disease, same as DLBCL. And if we go by GP, go back to the previous slide. Excuse me, go back to the previous slide. Is it audible? Yeah. So if we classify them by gene profile, two subtypes came out: germinal B cell, GCB, and activated B cell. Next slide. And we all knew that addition of rituximab anti-CD20 to CHOP in first line improved DFS and OS also. And almost 60% of patients achieved cure. 10-year OS was about 43% versus 27% in CHOP form. And even if patient relapse, about 40% are bound to relapse. They bounce back and almost achieve a very good PFS about 36.5% in long term. And despite multiple attempts, still RCHOP is a standard of care. Next slide. So I can say that RCHOP is effective but not perfect, as we have achieved almost 100% cure in testicular tumor, choriocarcinoma, Burkitt's, and even better in pediatric ALL. It is also one of the blue cell tumors. Why can't we achieve almost to the tune of 90% so? So at this point of time, long-term survival is almost 60%. Next slide. So it is a bracket. Go back, go back. So this is the area, initial area where patient are bound to relapse back, non-responding primary progressive lymphomas, and about 40%, you can see almost 40% start showing by the year of 5 years. So long-term survival is almost 60%, but this is area on which we have to work, in which if we can achieve this curve going like this, so that almost 80% should be here. Next slide. So strategies to improve on the outcome achieved by R-CHOP. How we can achieve? Either we can intensify the dose, optimizing with anti-CD20 agents, addition of new agent, or alternative rituximab-based frontline regimens. Next slide. So first, dose intensification. Can we intensify the dose and achieve better PFS, OS? Next slide. So these are the two trials in which there is addition of one more drug. In this case, it is a bleomycin which has been added. And if we decrease the frequency, instead of 3 weeks, let's go to the 2 weeks regime. So almost you can say that in this case, it was similar event-free survival at 3 years. But we could see, in fact, in slides it was a little wrong, we could see more of the grade 3-4 neutropenia with R21 because R-CHOP 14 was potentiated with, or it was with the GCSF reflexes. And in the first study, serious events were more in the 5-drug regime, and almost, the subgroup was 18 to 60 years of age. So it represents a very small subgroup. So henceforth, we could see there is an improvement of about PFS of about 14% and OS of about, you can say, 8%, but it is not translating into a benchmark difference at the cost of serious adverse events. Next slide. Next slide, yeah. So coming again to dose intensification, in this case, we have added etiposide. So it is R-CHOP and addition of etiposide as a front line. Again, PFS and OS were similar in both regimes. There was no survival advantage, but grade 3-4 adverse events were in the more intensive arm. So henceforth, we will continue with the R-CHOP. Next slide. Coming to the optimization of anti-CD20 agents. Next. In this case, there is a phase 3 study in which another anti-CD20 antibody, which is obinutuzumab, which is humanized instead of chimeric rituximab. This is a Goya trial, and final analysis revealed 5 years PFS of about 63.8% versus 62.6% for R-CHOP, and hazard ratio of 0.94%. P value was not very significant, but we could see more adverse events and serious adverse and fatal events in the obinutuzumab in the first line. Next slide. So again, we are not achieving greater difference of PFS and OS at the cost of the adverse events. So if we add upon a new agent along with the CHOP, so rituximab is already there. So this is a cell pathway. Rituximab is working on CD20 cell membrane receptor, and rituximab anti-CD30. Then toll-like receptors they are working in myeloma patients. So they are targeting kappa B pathway like bortezomib and interferon receptor factor 4 pathway for like lenalidomide, and we are protein tyrosine kinase like pathway by glutinidine CLL, myeloma, and it is for the classical B cells. So practically they all are round blue cell tumors, and we can either in combination or in isolation we can use the additional agents over and above rituximab. Next slide. And similarly, we utilize cell pathway. So this is using now the gene expression profiling. So in this case, if we take by cell of origin by genetic profile, we have subdivided this DLBCL into two subtypes, ABC subtype and non-GCB subtypes. And we know that ABC they have more aggressive disease, they have more chances of CNS relapse, they fare much worse with the conventional treatment based upon the rituximab as compared to the rest of the subtypes. And if we go by the FISH for the gene rearrangement, we classify lymphomas, DLBCLs into other double hit or triple hit based upon the c-Myc, BCL2 or BCL6 or both pathways. And we know that double hit and triple hit lymphomas fare poorly with a conventional treatment, and they need more intensive treatment in form of hyper-CVAD or even more intensive treatments. And by IHC, if we come to know by the c-Myc and BCL2 protein overexpression, the cutoff level is about 40% for c-Myc and 50% for the BCL2. Again, double hit and triple hit lymphomas fare worse as compared to the rest of the lymphomas, and they don't respond very well with the conventional R-CHOP, and they have higher chances of CNS relapse. Next slide. So coming to the Phoenix study, we added ibrutinib in untreated patients, and ibrutinib plus R-CHOP didn't improve event-free survival and OS. Yes, it definitely improved EFS in patients less than 60 years of age, but on the contrary, they fare worse in patients more than 60 years of age in form of more serious side effects and infections, especially with the induction of ibrutinib. Next slide. And if we included lenalidomide in robust trial, a similar outcome. Almost they didn't improve the efficacy over placebo versus R-CHOP. Next slide. So, addition of an extra drug to the conventional first-line R-CHOP regimes in patients with standard DLBCL resulted in trend towards improved disease control compared to standard R-CHOP. But however, there is no significant change in response rates or overall survival. And hence, R-CHOP plus X, either of the drug, either you use ibrutinib, bortezomib, lenalidomide, they are associated with an increased risk of serious grade 3 or 4 hematological adverse events. Until this time, R-CHOP is gold standard of the treatment of DLBCL. So what best can be done now? So this is an article which appeared in NAGM, which utilized polatuzumab, which is anti-CD79B antibody, instead to utilize this in the POLARIX trial. Next slide. And it was double-blind, placebo-controlled randomized trial, well balanced, and almost polatuzumab plus R-CHOP till 6 cycles, and rest of the 2 cycles, 7 and 8 cycle was rituximab in the both cases. So primary endpoint was progression-free survival. Come to the next slide, please. Yes, in this trial, we could achieve a hazard ratio of 0.73. That means that translated into about absolute 27% risk of reduction of early disease progression, relapse, and death, and 6.5% benefit of a progression-free at 2 years. Next slide. But again, like previous trials, there was no significant overall survival benefit. It was 88.7% versus 88.6% between the two arms. Hazard ratio was 0.94 and p-value was not significant. So again, in this case also, even if we added another antibody, anti-CD79B, we couldn't get the desired result, which was primary endpoint and secondary endpoint. Next slide, please. Coming to the safety profile, almost you could see that there were more serious events as in this polatuzumab arm versus R-CHOP arm, which is standardized. Next slide. Now, if we add venetoclax, as we all know BCL2, if we add R-CHOP to that, so in this trial, we took more than 80 years of patients. They were better performance status patients, PS1 and 2. And venetoclax was added for 6 cycles with additional 2 cycles of venetoclax plus rituximab after the R-CHOP is over. And comparative analysis was used. And in this trial, addition of venetoclax to R-CHOP in first line DLBCL demonstrated increased but manageable myelosuppression and potential of improved efficacy, particularly in high-risk BCL2, IHC plus. The cutoff was 50%, subgroup patients. Next slide. So these are the 7 trials, or meta-analysis of 7 trials, which utilized additional agent in either either bortezomib, ibrutinib, lenalidomide, even gemcitabine versus R-CHOP. Next slide. So if we use an alternative principle-based frontline regimes, what could be an outcome? See, this time we tried to add upon additional pathway. For example, used glutenate, venetoclax, lenalidomide, even anti-CD20 humanized antibody, but outcome was almost yes. They had some better response. PFS for initial some time, but when followed over a long time, the OS was not different. So henceforth, till this time, in the first line, R-CHOP still is a standard with manageable toxicity. But if we try to manage with the chemotherapy arm, let's see what is happening. If we replace doxorubicin with epirubicin, so this can be possibility, especially in the patients. We know that anthracycline is contraindicated with the cardiac dysfunction. Sometimes we used to use metoxantrone. But if we compare the historical control, the overall 5 years OS was lower than these controls, and almost TTP was similar in the both subarms. So either you replace epirubicin with doxorubicin, the difference is not very stark or it is not significant, so that we can replace it with a conventional R-CHOP. R-GEMOX, yes, especially in the old age patients, it is almost equally efficacious, but they have low incidence of grade 3-4 toxicities. Yes, this can be an option in old age patients. Instead of using R-CHOP, you can use GEMOX. Like follicular lymphomas, first line bendamustine and rituximab, yes, this can be again tried in older, poor performance patients. But PFS and OS were almost similar with the standard R-CHOP. Next slide. So can we now tailor chemotherapy for heterogeneous R-CHOP? As we all know that, heterogeneous DLBCL, we all know. Hold on. That DLBCL is a group of disease. It is not a single entity, which is physically, phenotypically, and genetically different disease. So if we genetically subtype divided rituximab based immunotherapy, this is a study, phase 2 study, in which it appeared in NGM. We subdivided on the base of GP into these subgroups: MCD-like group subgroup, BN2, N1, EBZ, this P53 mutated, and others. So we gave different drugs based upon the analysis that what can be a different outcome if we use different drugs along with the standard R-CHOP, as we had been trying earlier also. But this time we used genetic profile of the patient and subdivided into these subgroups. Next slide. Yes, now there is a ray of hope. We could see that there is a difference of CR rates with if we genetically modify the treatment as compared to R-CHOP, conventional R-CHOP, which translated into the better PRs, stable disease. And if you see this arm, that there is a primary progression with R-CHOP is about 17% versus 3% with the disease stratification based upon the genetic profile of the patients. So next slide. So first is that it has met its secondary endpoint also, that is PFS. The 1 year PFS was 93% versus R-CHOP 73%. So there is a big difference, and it's a phase 2 study. We need larger studies, comparative trials, whether now we can strategize our DLBCL patients based upon the genetic profiling, as we are doing with the SMART in myeloma, as we are trying to do with other in ALL also, in AML also. So this study holds a ray of hope that in coming years we cannot utilize one standard of treatment or standard of care R-CHOP for DLBCL first line. It can be modified according to the gene profile of the patients. You get a GP done, and whatever outcome comes, bracket that patient into that group, and according to that, the drugs which are more effective in that group, you can combine R-CHOP with that adjunct treatment. So it is R-CHOP plus X. So this may, as it is showing in phase 2 trial, that there is a difference of PFS in 1 year, that may translate into longer PFS or longer follow-up, and which ultimately will translate to the gold standard, which is OS. So we have to click beyond 60% of long-term cure with the R-CHOP and DLBCL first line. Next line. So expected more or less similar adverse events with the standard R-CHOP and with the addition of one drug. Next line. So let me summarize dose intensification strategy. More is necessary, but may not be better. Addition, right away, no advantage, but with the previous phase 2 trial, there is a ray of hope that if we profile the patient into genetically heterogeneous groups and accordingly we add upon a drug, not blindly to everyone, definitely that can translate into a better outcome in form of PFS and OS. And risk-adapted approaches, identification of cell of origin, molecular markers, delineating the potential prognostic importance of entire PET scans. I have not enumerated the use of PET scans, but yes, we know that initial after 2 cycles, if you get a PET scan, if there's a better response, that translates into better PFS and OS and better CR as compared to the primary progressive lymphomas. What else will be required to replace R-CHOP? Better phase 3 studies, use of novel approach, which has a better efficacy and low toxicity. It should be tolerable in majority of patients, and even if toxicity has to be poor, it should be much less as compared to the benefit which is going to with the additional new regime which will be tailored. Deliverable and affordable. Affordability is a big problem in India, and majority of our new drugs basically we cannot utilize because of financial toxicities. And if target to a molecular subgroup has to be done, like required a validated biomarker is needed for the appropriate patient, as it has been seen in the last slide, in which we have tailored the subgroup of patients as per the gene profile. Next slide. Thank you. Thank you for patient hearing. I try to summarize in a minimum short time so that at least we can open to for discussions. Over back to the uncle.
Thank you, Dr. Rajiv, and thanks for the nice presentation. Yes, it's true that R-CHOP still remains the gold standard in DLBCL, but the molecular studies is one which can change the treatment options later on. As we have ma'am with us, Dr. Reena Nair, ma'am is already there, so we can have the added advantage of her reviews on this addition of X in R-CHOP. Ma'am, your comments for the same.
A very nice presentation, completely covers the topic as it stands. We've all been disappointed in the last 15 years with whatever randomized trials we've done. Nothing has broken the backbone of R-CHOP. So, nothing to feel disappointed. There was a time when we used to say nothing, means there'll be nothing which will cross-CHOP. And then suddenly one day rituximab came and everything from complete response, PFS to overall survival, everything changed. I think the way they are going ahead with this trial is good. We can't put all the DLBCLs in one basket and say just add one, because that's where I think the results get diluted. And we need to actually find the subtype of DLBCL which will benefit from the X that we are adding. We know for certain that in cell of origin, there are some ABCs which are good ABCs. There are some GCBs which are bad GCBs. So just the IHC is not going to help us. Gene profiling will help us, but at the moment is expensive. And as trials come in and gene profiling becomes little less expensive, we perhaps will find the answer. Only, when you have a lot of white hair and you see PFS of 20% in excess of the standard arm, you know that we saw it with the second and third generation of chemotherapy drugs like Macrob and Mbacod and so many other very toxic regimens, and then CHOP became the standard. And now also with trying to improve on the anti-CD20, trying to put in another drug, we have seen that really nothing has happened except the PFS shifts a little. And so I will wait till these results are finalized and not take it, as gospel truth and start adding drugs, because remember, if we just add toxicity and we reduce the dose intensity of the CHOP, we actually lose 20% of the benefit we are giving to our patients. So from the data that we have seen, if we just give the standard chop in the standard doses to as many patients as we can, we actually improve our old data, and we also come up to 66% long-term outcomes. So at least keep that going. Don't meddle till you have something which is absolutely promising and can be put into practice with good evidence.
Thank you, ma'am.
Dr. Ina, I have one question. Can I ask?
Sure, sir.
God has been very unkind to males. So it is in case of lymphomas also. I came across that if we increase the dose of rituximab to 500 milligram per meter square, so
Just repeat that.
that if we increase the dose of rituximab to 500 milligram per meter square as against the standard 375, it adds in males itself. So are you practicing this gender bias, or it is
No, I'm
standard?
not.
Okay.
No, I'm not. I'll tell you, this is from the British trial when they had first shown that the males needed the maintenance therapy, and they said it was the bioavailability of rituximab which was different in the two genders. So either increasing the dose or giving the maintenance would make a difference in the male patients. But now, there has not been another randomized trial, but there's a lot of real world data which has challenged. And I think finally, a randomized trial is very good because it gives you an answer. But if you have to put it into practice, the real world data takes over immediately. And if it is not making a difference in the real world, then really to add on, in India, rituximab is quite reasonable and we can almost give it to every patient now. But remember, everywhere else, it is not really that reasonable. And the other thing is, if you look at let's say the pharmacokinetics of rituximab, then we know that in maintenance, we are using it once in 3 months, which means till 3 months, the effect of rituximab lasts. And so really, is there a point in increasing the dose when 375 milligrams has been the standard dose? And the last question is, the 375 came up in a very non-scientific manner. They had a certain amount of rituximab. For their phase 2 trial, they had certain number of patients, and so they just divided it by the number of patients and came to 375. 375 is not a scientifically derived dose. So many people feel that even if we were to give less than 375, the effect would be the same. So you're asking for increase. I'm actually arguing on
You want to
actually
de-escalate.
decrease the amount, but let's keep it at 375 because that's the most proven disease in a disease which is very highly curable. So no tinkling.
So that's why I was pressing upon for a higher dose, since I knew it's a curable disease in the initial curve of first 2 years. It
Yeah.
gives short nose dip of about 25%.
When rituximab came, we used to give 2 doses in every cycle. We did not give one. So we gave on day 1, day 2, or we gave on day 1 and after the 5th dose of prednisolone. So that actually means we were giving double the dose at that point of time, and it did not show any benefit at all. So we don't really increase the dose, except in CLL, where for some time we did increase the dose, but I think the BR combination has been so effective that there also we have come down to 375.
Thank you, ma'am. And if any other queries are there, so we can take it. Otherwise, we are running a little behind the time, so scheduled time. We can proceed with the next session. If ma'am you allows us and Dr. Rajiv, if you allows us, then can we switch to the next session?
Yeah, thank you, of course, and thanks everyone for their time.
Thank you, everybody. So next session is EHA update on CLL management, and that will be discussed by Dr. Ankush Jain. He is a senior consultant and at the Department of Hematology at Safdarjung Hospital, Delhi. Welcome, Dr. Ankur, and over to you, sir. Dr. Ankur, your mic, yeah.
Dr. Ankur, am I audible?
Yeah, you are. Now you're.
Thank you so much for inviting me for this wonderful virtual webinar. And I'm privileged to present updates on the management of CLL. Slide sharing, please. Slide sharing. My presentation is not visible. Yes. So Okay, so I'll be in the coming half an hour or so, I'll be presenting the updates on the management of CLL from the this year's EHA as well as from the previous year's data. Next slide, please. Next slide. So CLL is a chronic condition, as we all know, and the median age at diagnosis of CLL is around 7th decade. In India, it is around 6th decade that we see majority of patients of CLL. And by this age, most of these patients have various comorbidities. So, which means that the therapy which is to be given for patients of CLL has to be tailored according to the comorbidities. So before the era of novel agents, the treatment of CLL was based upon the presence or absence of high-risk features. Those who did not have any high-risk feature, which means there was no deletion 17 or IGVH unmutated status. For young patients, we used to give chemoimmunotherapy in the form of FCR or PCR. And for the older patients, we used to give chlorambucil or bendamustine-based chemoimmunotherapy. The novel agents were given for patients who were high risk, which means either deletion 17 or IGVH unmutated. And these novel agents were also given to patients in the relapse and refractory setting. Next slide, please. Next slide, please. But over the past 1 decade or so, there has been a paradigm shift in the management of CLL. Now, in this paradigm shift, we could see that in the recent NCCN guidelines, irrespective of the presence or absence of deletion 17 or the younger or older patients, the preferred regimen is the novel agents. So whether the patient has deletion 17, whether a patient does not have deletion 17, young patient, old patient, everyone is to be managed with the novel agents, and preferred first-line regimens we could see are the BTK inhibitors or the BCL2 inhibitors with or without a monoclonal antibodies. Next slide. So patient with deletion 17 also and without deletion 17 also, the first line regimen remains by and large same with only few exceptions. And in the subsequent slides, I will be discussing the various randomized trials and why the NCCN and the other expert agencies have come up with the use of novel agents in patients of CLL. I shall be discussing them in the subsequent slides. Next slide, please. So when we decide the treatment for patients of CLL, we see the IGVH mutation status and we see the presence or absence of deletion 17 by FISH, and IGVH we do by the Sanger sequencing. It is very important to know that as the disease evolves, the status of deletion 17 could change, which means that patient might not have deletion 17 at the baseline, and as the patient's disease progresses, he or she may acquire deletion 17. However, the IGVH mutation status is similar across the disease spectrum. It usually does not change. Next slide, please. So how do we choose between chemoimmunotherapy or novel agents, and why these guidelines have come up? I will be showing this in the subsequent slides. Next slide, please. So coming on to the first BTK inhibitor, which is ibrutinib. So ibrutinib, there are various randomized trials, both in the older patients as well as in the younger patients. When I mean older patients, I mean those who are above 60 years of age, and those who are below 60 are referred to as younger patients. So there are 3 randomized trials which have compared ibrutinib with the chemoimmunotherapy in the older patients. First of them is a RESONATE trial, which has compared ibrutinib to the standard of care, which is chlorambucil monotherapy. Second is an Alliance trial, which has compared ibrutinib with or without rituximab as compared to bendamustine rituximab. And third is the Illuminate trial, which has compared chlorambucil obinutuzumab versus ibrutinib obinutuzumab. So all these 3 trials were done for the older patients. I shall be discussing RESONATE 2 trial. Next slide, please. Next slide, please. So in this EHA, we could see the 8-year follow-up from the RESONATE 2 trial, which has compared ibrutinib versus chlorambucil monotherapy in the older patients of CLL. And as we could see that there is a clear progression-free survival benefit of using ibrutinib for patients with deletion 17, without deletion 17, as well as irrespective of the IGVH mutation status, which means that whether patient is IGVH mutated or unmutated, or whether or not there is deletion 11 or even deletion 17, ibrutinib provides consistent progression-free survival benefit over chlorambucil in an 8-year follow-up of the RESONATE-2. Next slide, please. As far as the side effects are concerned, side effects are very consistent, and we know that ibrutinib causes a lot of hypertension, atrial fibrillation, and bleeding. So these three are the classical side effects of ibrutinib, and they were significantly higher in the ibrutinib arm as compared to the chlorambucil arm. Next slide, please. So one thing which is very clear cut from the real world data of the ibrutinib is that around 1/5 of patients, which means around 20% of patients who take ibrutinib long term, they have discontinuations, and majority of discontinuations because of ibrutinib are due to the side effects, and some of the discontinuations are because of the disease progression, but majority of discontinuation of ibrutinib are because of side effects. And in clinical practice, we see that patients discontinue ibrutinib majorly because of bleeding events, and some of them have cardiac events also. Next slide, please. So although I have shown RESONATE-2 trial, I have not shown Alliance trial and the Illuminate trial, but I am presenting a summary, a combined summary of all the three trials. So if we could see that as compared to chemoimmunotherapy, in all the three trials, ibrutinib offers a consistent progression-free survival as compared to chemoimmunotherapy, whether irrespective of deletion 17 or the IGVH mutation status. The only exception is the Alliance trial, which compared ibrutinib with bendamustine rituximab. And in that trial, those patients who were IGVH mutated, in that subgroup of patients, there was no progression-free survival, which means that in an older patient who is IGVH mutated, we could still use bendamustine rituximab, whereas for all the other group of patients, all the other risk group of patients, ibrutinib is clearly superior to chlorambucil or bendamustine rituximab. Next slide, please. So the data regarding the younger patients with the ibrutinib, there are two randomized trials. One is the ECOG ACRINE trial and another is the FLAIR trial. In both of these trials, the ibrutinib has been compared with the FCR backbone, because we know that the FCR is the standard of care for the younger patients with CLL. And in both of these trials, patients without deletion 17 were taken. And we could see that the ibrutinib is clearly beneficial. It clearly improves progression-free survival over FCR in young patients of CLL. Again, the only exception is that patients who are IGVH mutated. In that subgroup of young patients, there is no PFS and overall survival advantage of using ibrutinib over FCR, which means that in a younger patient of CLL who is IGVH mutated, we could still go with the conventional chemotherapy as compared to the ibrutinib. Next slide, please. So I would like to conclude the data of ibrutinib with that ibrutinib improves progression-free survival as compared to chemoimmunotherapy in both the younger and older patients with CLL in all the risk groups, except those who are IGVH mutated. So those who are IGVH mutated, if they are young, we could use FCR, and those who are older, we could use BR. For all other category of patients, ibrutinib is now the standard of care in the management of CLL. Next slide, please. So next BTK inhibitor, or the second generation BTK inhibitor, is the acalabrutinib. So acalabrutinib is a congener of ibrutinib, and it is used in a dose of 100 milligrams twice a day. As we could see in this diagram, that acalabrutinib has lesser off-target effects in addition to BTK as compared to ibrutinib. And because of the lesser off-target activity, the side effect profile of ibrutinib is lesser as compared to acalabrutinib is lesser as compared to the ibrutinib. Next slide, please. So with regards to acalabrutinib, I would like to show the two randomized trials. The first one is the ELEVATE-TN trial. The ELEVATE-TN trial compared acalabrutinib with or without obinutuzumab to the classical or conventional regimen of chlorambucil obinutuzumab in the treatment-naive CLL. And in this EHA, there was a 5-year follow-up of the ELEVATE-TN data. And if it is very clearly evident from these Kaplan-Meier curves that acalabrutinib arms had a significantly better progression-free survival as compared to the chlorambucil obinutuzumab arm. And this progression-free survival was seen irrespective of the deletion 17 or the IGVH mutation status. Next slide, please. So in patients with or without IGVH mutated, the above graphs, the above Kaplan-Meier curves are the PFS curves in patients who had IGVH unmutated, and the below mentioned Kaplan-Meier curves were seen in patients with IGVH mutated. In both of these categories of patients, the acalabrutinib did better as compared to chlorambucil obinutuzumab in terms of progression-free survival. Addition of obinutuzumab to acalabrutinib further improved the progression-free survival, but also had significant added adverse effects. Next slide, please. So as compared to the safety profile, we know that acalabrutinib versus chlorambucil arms. So acalabrutinib definitely had higher cardiac events and higher bleeding events and hypertension, which is a class effect of the proton kinase BTK inhibitors. Apart from that, there were no major concerns, and acalabrutinib with or without obinutuzumab was considered a safe regimen in treatment-naive CLL patients, and the side effect profile was almost similar to patients with chlorambucil obinutuzumab. Next slide, please. So another randomized trial which I would like to discuss with acalabrutinib is the randomized trial of acalabrutinib as compared to bendamustine rituximab or adalimumab rituximab. That was an ASCEND trial, and in this EHA we had a 4-year follow-up of the ASCEND trial. So in both of the Kaplan-Meier curves, we could see that acalabrutinib had a significant prolongation of progression-free survival as compared to the bendamustine rituximab or the adalimumab rituximab. Now that was in the relapse and refractory setting, whereas the Elevate TN trial was in the treatment-naive setting. Next slide, please. And again, similar to the Elevate TN trial, this PFS benefit was seen irrespective of the IGVH mutated or the deletion 17 status. Now, this advantage of acalabrutinib is different from the ibrutinib arm, because in the ibrutinib arm, there was
So request you to conclude your session in 1 minute. Thank you.
Okay. Next slide, please. Next. So next slide, please. So acalabrutinib improves PFS irrespective of the genomic status. Next slide, please. Coming on to the Elevate RR trial, which compared acalabrutinib versus the ibrutinib. So which is better in patients of CLL? So there was Elevate RR trial, which was done in patients with a relapse refractory CLL. Next slide, please. And we could see that there was no significant PFS difference between the acala and the ibru arms, which means that there was a non-inferiority of the acala and ibru in the RR CLL. Next slide, please. Side effect profile was almost similar, except that acala caused more headaches and more cough, whereas ibru caused more diarrhea. Next slide, please. Which means that acala is better tolerated as compared to the ibru in patients of CLL with effect from the except diarrhea and the arthralgias, which was diarrhea which was more in the ibru arm. Next slide, please. Another third BTK inhibitor is a zanabrutinib, and it has been compared to the bendamustine rituximab in patients with CLL. And we could see that zanabrutinib improves PFS as compared to BR in patients with CLL, although the overall survival is same. And this advantage is irrespective of the del17 or the IGVH mutation status. Next slide, please. As far as side effects are concerned, zanabrutinib is well tolerated, and side effect profile is almost similar. There was no significant difference apart from the bleeding, which was more in the zanabrutinib arm. Next slide, please. So another trial compared zanabrutinib versus ibrutinib in the relapse refractory status, which was the Alpine study, and this was done in the relapse refractory setting. And very interestingly, in the relapse refractory setting, zanabrutinib was found superior to ibrutinib in terms of progression-free survival. However, the overall survival was similar. Next slide, please. And side effect profile was almost similar, and except that the ibrutinib caused more atrial fibrillation and zanabrutinib caused less atrial fibrillation as compared to ibrutinib. Next slide. Next slide, please. Coming on to the venetoclax, which is the BCL2 inhibitor. Next slide. So BCL2 inhibitor was compared with the chlorambucil obinutuzumab in the CLL14 trial, and in this EHA we could see the 5-year follow-up data. And venetoclax, combination of venetoclax Ven-G, which is venetoclax and obinutuzumab, is superior to chlorambucil obinutuzumab in all the patients of CLL, irrespective of the risk status. As per side effect profile, both the arms were essentially similar in terms of the side effect profile, and there were no significant difference in the side effects. Next slide, please. Murano study is a phase 3 study which compared VEN-R with the BR in relapse refractory status, and we could see that VEN-R improved PFS as compared to BR in the relapse refractory CLL. Next slide. And then we could see that most important thing is that venetoclax-based therapies are time-limited therapies, which are usually given for 1 year or 2 years, in contrast to BTK inhibitors, which are to be given lifelong. So at the end of treatment with the venetoclax-containing therapy, the subsequent PFS depends upon the MRD. Those who are MRD negative at the end of study, they remain MRD negative at the 2 years and 3 years follow-up. So this is a Murano follow-up data, which shows that the MRD status at the end of treatment is a significant predictor of the future PFS in these patients. And I would like to conclude that venetoclax again improves PFS as compared to CIT in all patients of CLL, except those who are IGVH mutated, because in these patients, the when G was found to be similar to the chlorambucil obinutuzumab in the CLL14 trial. Now the burning question is that how do you choose between a BTK inhibitor and the venetoclax? So BTK inhibitor, once we start, we have to give lifelong therapy, and when venetoclax-based regimens are to be given for a fixed duration of time. So I would like to conclude that is there any role of chemoimmunotherapy in the CLL today? Yes, only in 3 subgroup of patients, those who are IGVH mutated. So young patients, IGVH mutated, we could use FCR. Old patients, IGVH mutated, we could use BR. And chlorambucil obinutuzumab, again, old patients who are IGVH mutated. Coming on to very quickly combination therapy in CLL from EHA. Next slide, please. So in this EHA, we could see CLL13 trial, and we could see that the combination of venetoclax with ibrutinib with obinutuzumab, which is IVO, was compared to the CIT, and IVO improved progression-free survival as compared to CIT in all the patients of CLL. Next slide, please. So we could see that IVO improved PFS in patients who are IGVH mutated or unmutated. The only exception is that patients who are young, less than 65 and IGVH mutated, in that there was no PFS advantage of a triple IVO as compared to CIT. Next slide, please. Safety profile, by and large, there were no safety concerns. Next slide, please. So Captivate is a phase 2 trial which looked into the combination of ibrutinib and ven. And in this EHA, we saw 3-year follow-up data from the ibru-ven combination. The ibru-ven combination improved progression-free survival in all the patients, and there was a 3-year significant PFS. There was significant PFS advantage with the combination of ibru-ven. Next slide, please. Next slide, please. Next slide. Am I audible? Okay.
Yes,
so
sir,
again, in the Captivate data, again, there is no significant safety concerns with the combination of ibru and ven. Next slide. Next slide. Okay, so finally, FLAIR trial compared combination of ibru-ven versus
Garima, means was there some network issue? What happened?
I think there was some network issue, but
Dr. Ankujan has joined again, I think.
There was a network issue, I think, and only 1 or 2 slides are left. So if Garima can just share my screen, only last couple of slides are left, and majorly I have covered. So I'll take 2 more minutes and finish off my presentation if the time allows and if Dr. Ankur allows.
Go ahead, sir. No issues.
So Garima, can you just share my slide if that's possible?
Yeah, please start.
Because there was some network issue in my slides and my internet got disconnected. Garima, no, I could not see. I could not see my slides. Garima, I could not see my slides. Slides.
Dr. Ankur, can you right now?
Garima, please. Otherwise, I would like to just finish off my session by saying that novel agents. Okay, even if there are no slides, I would just like to finish off my session by saying that novel agents, whether inhibitors or BCL2 inhibitors, are now the frontline treatment options for patients with CLL. Only for those who are IGVH mutated, in those group of patients, we could still use chemoimmunotherapy, younger patients FCR, older patients BR. Otherwise, for all the patients, novel agents, definitely. And now with this EHA, we could see that there are combinations of novel agents, which whether ibrutinib combination or ibrutinib obinutuzumab combination, which are coming up. The few considerations which we have to keep.
I think there is.
Yeah, I think so. There is network issue at Dr. Ankur's end.
I think so. So it again disconnected.
Yes, sir. So can we move on then, sir? What do you suggest?
Dr. Ankur has joined again.
Okay, yeah, she's there again. Garima, can you share the slide again?
Dr. Ankur? Yeah, I think there is some network issues going on.
Network issue, but I would just like to conclude that ibrutinib has to be given lifelong, and whereas venetoclax is a time-limited therapy, ibrutinib cannot be used in patients who have got cardiac comorbidities. So when we have to choose novel agents, we have to consider these things and we have to discuss these things with the patients. So I think I would like to conclude these thoughts, and I would like to take further questions if there are any from you or ma'am or for any other participant. Thank you so much.
Thank you, Dr. Ankur, for a wonderful discussion, and we are really sorry for that inconvenience because of some network issues. We know these things happens with the virtual meets. So since COVID, we are facing some issues. After your discussion, it seems that soon the CLL management will shift to some oral therapies only, as we are shifting through chlorambucil, then IV targeted therapies, now ibrutinib, acalabrutinib, then zanubrutinib, and venetoclax. So the future will not be the future will be like kind CML, that just the oral therapies and the patient will be done. As there are no questions and we are running behind the time, so we'll jump.
Dr. Ankur, one query I have, Dr. Mukesh here.
Yeah, Dr. Mukesh.
Yeah, thank you, Dr. Ankur, for such a wonderful presentation. Just need to know patient with 17p deletion and unmutated IGVHV mutation. So what do you prefer? Still CIT or ibrutinib based therapy?
Patients who are deletion 17 mutated, there is clearly no role of chemoimmunotherapy. Clearly no role of chemoimmunotherapy. So in these patients, we always use novel agents. But in those patients who have deletion 17, I mean not a negative, and am I audible?
Yeah,
I think there is some internet problem. Okay.
You are audible.
But in those patients who do not have deletion 17 and those who are IGVH mutated, and that is a controversial area, because in these patients we could still use chemoimmunotherapy. So as far as your question is concerned, if there is deletion 17, there is no point giving CIT. You just go with the novel agents.
Right. Thank you.
Any other questions or anything else need to be discussed? So shall we switch to the next session? Thank you, Dr. Ankur Jain, for the wonderful presentation. So the next session is taken by Dr. Mukesh Chawla. He's a senior consultant hematologist and bone marrow transplant physician at Indus Hospital, Mohali. He'll be discussing regarding the improving outcomes in myelofibrosis. Dr. Mukesh, over to you.
Yeah, just like, thank you, Dr. Ankur. Can you see my slides?
No, sir.
Not yet.
Now?
Yes, sir.
Yes, we can.
Can you see the slides now?
You need to make it full screen, sir.
Now is it okay?
Dr. Mukesh, it's still in the slide mode. If you can switch, if you can change the slide 1, 2, then might be we can proceed like this only.
Yeah. So not able to change from here. Karima, can you share the slides from there? Do you have
Garima?
my slides?
Yeah, Garima is sharing.
Initially option was there. Yeah.
Dr. Mukesh, can you see now? Yeah.
Yeah, right. I can see. So am I audible?
Yes, Dr. Mukesh.
Yeah. So not wasting much time. Thank you, Dr. Ankur, for this such a wonderful opportunity and giving this platform to discuss. So we are shifting now discussion from lymphoma to another disease, myelofibrosis, where we don't have much of it's a non-malignant, not much of drugs and very poor over survival. Just go back once. So our discussion for today's topic is, Prima, can you go back first slide? So this talk is in association with Novartis. So we'll be discussing as we have JAK2 inhibitors, ruxolitinib in myelofibrosis. So we'll be discussing because as we have seen that there are poor oral survival in myelofibrosis. So we'll be discussing early usage of ruxolitinib in myelofibrosis and survival as a treatment goal. Does it have a really impact or no? Next slide. Next, please. Next. So as you can see, what are the clinical challenges with the realization of overall survival as goal to treatment? While the person is on a treatment with myelofibrosis, is overall survival considered as a tangible goal with available treatment options? That is our current discussion. And is it true for all or only a particular subset of patients? As we know that myelofibrosis will divide into low risk, intermediate 1, 2, and high risk. So are we going to stick only to the high risk group, intermediate 2, with the use of JAK2 inhibitors, or it is for all the subset of patients? So let's talk about the life extension of myelofibrosis patients. Next slide. So this is the pooled analysis from the Comfort 1 and Comfort 2 pooled analysis, where there was use of JAK2 inhibitor ruxolitinib versus the control groups or the best available therapy. As you can clearly see that with the use of ruxolitinib, there was increased overall survival probability in both the groups. So there were two groups, with the control groups and the other groups where there was crossover change off to the ruxolitinib. So adjusting to that also, there has been seen a overall survival ratios better with significant lower hazard risk ratio of 0.35% with a significant p-value. As you can see, the overall survivor is better in the ruxolitinib group than the control arm groups. Second slide. Next, please. So this is a discussion of, so as you can see, they have compared it from the last decade, from before 2010 to the 2010 comparison of the overall survival in patients with the available therapies in patients of myelofibrosis. As you can see clearly, with significant p-values in the overall survivor before the 2010 and after 2010, you see on the left side of the Kaplan-Meier curves. And if you see on the right side, they have divided depending upon the lower and higher risk also. As you can see, the overall survivor in this current decade with the usage of ruxolitinib, the overall survivor has been better in the both the groups with the lower IPSS scores also and the higher IPPS scores also. Before 2010 and after 2010, the overall survivor has been better with the use of the newer drugs. Next slide. So this is real world data among patients with intermediate 2. So no, they have used it only intermediate to high risk patients of myelofibrosis in the US and seen the impact of ruxolitinib after the approval. So they have divided into 3 groups. So before pre-approval, where they were not exposed to ruxolitinib, so around 119 patients were there, and group 2, this is post-approval but unexposed to the JAK2 inhibitors. and group 3 post-approval, where they have been exposed to the ruxolitinib group. As you can see, there were around 119 patients in group 1. And they were discussing the death rate. So around 42% in the group 1, where they're not exposed and pre-approval. Group 2, because of the better available therapies but not exposed to the ruxolitinib, the death rate was around 33.9%. But with the exposure to the ruxolitinib, the death rate has come to 19.9%. With the, as you can see, 1-year survival rate has increased markedly in the group 3 around 82%, and in group 1 around 55.6%, and in group 2 72.5%. So as you can see from the Kaplan-Meier curves also, the overall survivor is significantly improved in the group 3. This is again a pooled analysis from the Comfort 1 and Comfort 2, where they have correlated the reduction of the spleen volume at the analysis at the week 24 and compare it with the overall survival. So as you can see, there were two groups, ruxolitinib and the control group. There were reduction of the spleen size. They have divided into three groups. Reduction from 10 to 25%, 25 to 30%, 35 to 50%, and more than that. And they have seen the compared it with the number of events that had happened, and analysis was at week 24. So overall survival probability was better in the ruxolitinib group. As you can see, the dots were more on the left side. So the death rate events were less in the ruxolitinib arm than the control arm. So it was found that every 10% reduction from the baseline in the spleen length at week 24 was associated with 9% reduction in the risk of death in the ruxolitinib treated patients with a hazard ratio of 0.91%. So early predictors of response with JAK inhibitors. So what is your approach to the patient? So you look for the high risk markers like spleen more than 5 centimeter, symptoms, abdominal comfort, MPN 10 is the one score criteria to assess for that. Considering that any increase in spleen volume from baseline is associated with increased risk of mortality in myelofibrosis patient. So how should these patients be treated in clinical practice? Let's see that. So these are the impact of the patient characteristics on outcomes in patients who are treated with JAK1 or JAK2 inhibitor therapy. And they have found that, so these were the high risk characteristics, that the dependence on transfusion, high DIP scoring, and mutations like ASXL1 and EZH2 mutations predict shorter time to treatment free failure in myelofibrosis patients. Patients who are receiving ruxolitinib treatment. So patients who has these high risk characteristics like transfusion dependence, high score, and these mutations, the time to treatment failure was lesser in patients of myelofibrosis than the patients who had not these high risk characteristics. So clinical implication is these are patients who are in high risk categories and should be proceeded to hematopoietic stem cell transplant or should be considered for the upfront novel therapy trials. Next slide. So they have studied also spleen response affects outcomes of affects the outcome of the ruxolitinib treated patients with myelofibrosis. So as you can see, the overall survivor, as you have more spleen responses at 6 months, the overall survival improved. As you can see with the green light, where you have any spleen response rate, red is there when there is a no spleen rate. If you see on the right side, if you see, there are 3 lines. So the first one is stable responder and other one is unstable responders, and the red line is non-responders. So they have compared it with the spleen size reduction in patients with who have stable responses and with the unstable responses. You can see there is not much difference in the two arms. However, patients who don't have any spleen response have a markedly reduced overall survivor than the patients who have any kind of responses, but there is no significant differences if the patient doesn't maintain that spleen response. So baseline factors associated with lower spleen response to ruxolitinib include high and intermediate 2 risk disease, spleen size greater than 20 centimeter, high WBC count, delay in starting ruxolitinib treatment after diagnosis has been shown to reduce the overall survivor, and titrated doses less than 10 milligram BD doses. So this was study. So they have studied ruxolitinib in different studies, like in Comfort 1 and Comfort 2, you have seen intermediate 2 and high risk patients. And there are other studies like JUMP, Robust, and Italian studies where they have started early because the standard recommendation was to start in higher risk of group of myelofibrosis patients. So now they have studied in the intermediate 1 risk of patients in some trials. So they have found that early usage of ruxolitinib has been found to have a better responses, higher response rates, and lower toxicities, as you can see in this tabulated chart. So you can see that spleen response as 6 months was around 30 to 40% in Comfort 1 and Comfort 2 trials, how it was around 50 to 60% if we started in the intermediate 1 risk patients. And incidence of side effects like anemia, thrombocytopenia, and rate of infections were higher if we start late. And it is less than 20% mostly if we start early in intermediate 1 risk patients. So concluding from this, it can be said that intermediate 1 risk patients may possibly achieve higher response rates and experience lower toxicity than the patients with high risk patients. So the early, this translates to that early use might convert into better overall survivor with lower risk of higher response rates and lower toxicities. So in this, they have studied the type and number of non-driver mutations which predict the response duration to ruxolitinib in myelofibrosis. As you can see, the patients on the left side, the patients who have these mutations, any of these mutations versus who don't have these or any of these mutations, you can see the cumulative overall survivor was better in patients who don't have any mutations versus patients who have any of these mutations. On the right side chart, you can see that depending upon the number of mutations, the more the number of mutations, the overall survival decreases. So spleen reduction, so in this they have removed the cumulative factor of spleen reduction with ruxolitinib with only independent association with the molecular mutations. So what is the rationale for earlier use of ruxolitinib in MF patients? This was a retrospective Italian study with the number of patients around 408, and they have seen the spleen responses were lower if the time interval between. So these were the patients where they started in the intermediate 1 risk patients also. So the time interval between myelofibrosis patient diagnosis and the start was more than two years. Very large spleen or higher total symptom score, transfusion dependency, and lower platelet count, and high risk category if scoring of intermediate 2 or high risk. So they have found that the spleen or overall responses were lower in these kind of patients. So the influence of ruxolitinib dose, early myelofibrosis patients may tolerate a higher dose. So if you start early, they are able to tolerate, as you have seen in your clinical practice also, very high disease burden. You are not able to escalate doses. So this indicates that if we start early in the disease, they might be able to tolerate higher doses with less of toxicity. Patients starting with higher doses have a higher rate of spleen responses, and use of lower doses may also result in reduced efficacy. So can ruxolitinib modify the pathogenesis of disease? Let's see that. So as we know that in myelofibrosis, it is associated with bone marrow fibrosis. So they have studied any changes in bone marrow fibrosis over the grading time. They have seen that in the ruxolitinib group over the months, there has been gradual improvement in the bone marrow fibrosis, and it stabilizes over that. So 68 patients enrolled in phase 1 and phase 2, single arm open label. This was a study. And BAT cohort included 192 patients. So over there, so endpoints were, so study points were 24 months, 48 months, and 60 months. And they have seen as the duration of the therapy increases, the changes in the bone marrow fibrosis also reduces. So they have studied the modification of allele burden also in the cohort studies, a comfort study. And they have seen that the patients who are on ruxolitinib have a lower burden of JAK2 allele burden than the patients who are on in the placebo group or on the crossover group. Next slide. So mechanism, as we know that there are JAK1 pathway and JAK2 pathway. So JAK1 leads to apparent cytokine production and immune dysregulation, as a result leading to ineffective hemopoiesis or extramedullary hemopoiesis, and even alteration of microenvironment. So JAK2 is a clonal myeloproliferation driven leading to clonal hematopoiesis of increased WBC count. So they have seen that comfort 1, the effect of ruxolitinib on the metabolic and nutritional parameters also. So they have seen the changes in the serum albumin and the mean change in body weight. So they have seen that in the ruxolitinib arm, there have been better changes in the serum albumin levels and the gain of weight in the drug arm. So they have seen that it improves the renal functions also. They have seen that the patients who are treated with ruxolitinib have a significant p values in the improvement in their renal functions, as you can see, and are leading to a better renal functions over the time with the improvement. So you can see the more than 10%, less than 10%, it is better with the drug arm. Next slide, please.
So request you to kindly conclude your
Yeah, right.
presentation in 2 minutes.
So just 1 or 2 slides. So the current therapy, so we have seen that ruxolitinib has, if started early, has a better improvement in the overall survivor with the better responses in the spleen rate and overall survival and even their quality of life also. But still there are some unmet needs also, like in the management of anemia, thrombocytopenia, progression to the blast phase or acute leukemia. So these are the points of discussion, because as you know that this drug causes itself anemia and thrombocytopenia and doesn't prevent the progression to the blast phase, which can still happen in 5 to 20% of the patients. Another area is some patient discontinue multiple reasons because of inavailability, inadequate or no responses. So any benefit in challenging with the ruxolitinib, that is again the area of discussion. So next slide, please. So thank you so much. I conclude my discussion and open for any queries.
Thank you, Dr. Mukesh, for the wonderful presentation. And it seems like having Jakavi early, so the response rates are good in the patients who are high risk with high risk mutations and carrying high score.
Right. Thank you. Yeah, again, this is a very rare disease. The experience as a young hematologist has been very less. But I have, but I remember my patient who came with stroke, UTI, very multiple comorbidities. So as I started on Jakavi, the its spleen reduction has been less than 20%, but I am seeing significant improvement in quality of life. Though there are struggles with anemia, thrombocytopenia, and between, but definitely the patient who came bedridden is now able to perform all his activities. His ECG performance is 0 now. Though spleen is still there, but as you can see, the more the duration of usage of ruxolitinib, the more the responses are there. So you have to stick to the drug. What I have seen in 2-3 patients, you have to stick to the drug because the responses are little delayed, more in the higher risk of groups. So definitely with this data, the starting early might help. They are might able to tolerate the higher doses with better responses, because again in this I have seen the patients who are started, because these patients are started late as in intermediate or high risk, so you are not able to escalate to the full dose strength. But definitely a lot of responses are there, not complete responses. A lot of lacunae and unmet needs are there, which needs to be addressed. Group can also, the house can also contribute to that. Very little experience on this.
Yeah, true. If anybody wants to comment anything on Jakavi, so it's open. Otherwise, we are running short of time and we can switch to the next discussion. Thank you, Dr. Mukesh, once again. And
yeah, right. Thank you, Dr. Ankur.
We switch to the next discussion. So the next discussion is placing of imatinib, dasatinib, and lotinib in a CML. So now we have dasatinib as a generic molecule and it's easy available, and with patient assistance of nilotinib, so these molecules are available. So Dr. Reshma Roshan, she's going to speak on this topic. So she's consultant in Department of Clinical Hematology at SKIMS Srinagar. Over to you, ma'am. Ma'am, kindly yeah.
Yeah, good afternoon, everyone. So yeah, I'm on my slides. Thank you for your introduction. Miss Garima, can you load my slides?
And we don't have your slides. Can you please mail me your slides?
Just a minute. Just give me a minute. Here's so are my slides visible?
Yes, Dr. Reshma, they are.
Sure. So my topic is placement of TKIs in CML. I don't think anyone who is practicing hematology right now has any doubt about the role of TKIs in CML that have revolutionized the treatment. So just before I go through the presentation, there's an overview. The introduction of TKIs for CML, we all know, has profoundly changed the patient experience as well as the doctor experience. Life expectancy is almost as of the normal population if they are lucky enough not to progress. There are differences between TKIs, but it is mostly the patient profile which we need to see. And we have to monitor the response, manage the toxicities, and see the regular monitoring. There's a multidisciplinary team approach, given that CML is a chronic disease. By the time they reach their middle age later, they may have multiple other comorbidities and may need drug change as per their other comorbidities. Optimal treatment selection, adherence, and monitoring will need to consider how safely to discontinue treatment. That is what is coming latest in this disease, where earlier it was thought that drug is to be continued lifelong. But with the newer trials coming with deep molecular responses, we may be able to give a drug-free periods to the patient. Switching to a new treatment due to disease progression or intolerance is one of the important things which we need to see. So we have at least 4 approved BCR targets upfront. 3 are definitely upfront. Asciminib is still not available in the country except for compassionate use. We started with imatinib, well tolerated, a wonderful drug, still first line in most of the situations. Dasatinib, nilotinib followed almost a decade later with an excellent data, followed by bosutinib, which has its own role. Ponatinib, our only savior in T351I mutation. And asciminib, which I said it's still not available freely and is available only on the compassionate use. So primary management of CML is relatively easy. It's just like a diabetes or hypertension. If there's no BLAS, so-called score, or other scores, whichever we are following in our practice is not high, you start with a simple tablet. The patient is relieved, the doctor is relieved. There's no intensive chemotherapy involved. So what we use as first line, I think it's more of an individual choice than a choice and a patient profile than a compelling data about the overall survival or anything. So it depends upon what is the patient profile. Obviously, patient is a young female who may have to have a childbearing in this future. You try to get her into the deep molecular response as soon as possible so that you can give them a drug-free remission later on. Or if it is an elderly male who has multiple comorbidities, cardiovascular disease, obviously you don't want to go to the nilotinib, or to someone who has pulmonary issues, effusion, you don't want to go to the dasatinib. So drug choice is more of a personalized, taking the patient considerations and taking the consideration of the disease at presentation. Maybe in future, we may have more of biological and molecular features, which will guide us which particular drug to start where. These are various scoring systems, which all of us know, and most of them have apps to calculate. It's not easy to calculate in OPD, but most of us have like small app and to calculate it. So this is what I said. When you get a new CML patient, to decide which drug to give, you first see what is the comorbidity status. If it is young, you want to go as deep molecular remission as possible. You start usually with the second line TKI. If it is elderly, where you don't want to go, you have already coronary artery disease, cerebral artery disease, or smoker with peripheral artery disease, you don't want to go to the nilotinib. If it is someone who's pulmonary artery hypertension, effusions, lung disorders, obviously you will avoid dasatinib. If there's hepatic impairment, you will try to avoid bosutinib. If there's renal impairment, imatinib is your only choice. So what is our data? I think with the more than 20 years of experience with TKI inhibitors, we have enough data, enough safety data, enough side effects data. IRIS was the first trial where the imatinib was compared to the conventional treatment of interferon cytarabine. We got enough data that imatinib is better than anything else in OS, PFS, side effect profile, and that was the magic bullet at that point of time. We have seen that 5-year OS, 10-year OS, but we have to see that if we see over the period of time, the OS drops, there are still many patients that progress. There are still many patients that are intolerant. So we need to have more drugs for more individualized choices. So this is Desazion. So soon after Iris, about a decade later, came nilotinib and dasatinib. Nilotinib was instead and dasatinib was for dasatinib, comparing both with the imatinib. Although at that point of time, it caused quite an excitement with PFS was the better, but OS did not differ later on, except for those with high score with nilotinib. So this is bosutinib versus imatinib. No doubt, all the molecular features are more deeper molecular remissions with the bosutinib as compared to the imatinib. You can see in the bar charts everywhere, wherever you want to see MMR, MMR 4.5 at 3 months, 6 months, 9 months, 12 months. Bosutinib is performing everywhere, molecularly better than imatinib. So if we see MMR, MMR 4.5, which are the new goals in the treatment of CPA-CML, we are no longer restricting ourselves to just the cytogenic remission, although still cytogenic remission is associated with overall survival. But to give a patient a drug-free remission, to give the deeper molecular response is the criteria. So if we see here also the higher risk group, the chances of getting an MMR 4 is still higher with bosutinib as compared to imatinib. So how do we monitor response? So as I said earlier, response monitoring is the most important criteria. And we have clear-cut ELN guidelines, when to get a warning, when to get, when to call ourselves a failure. And there's a clear-cut table that comes with all the RQ-PCR reports. Or if you don't have, you keep a page in your OPD or your CML patient file to see whether the patient has actually still in the morning or failure or is just doing the fine. So I'm not just going to, because what we need is it's to be less than 10% 3 months, less than 1% 6, and then it should be less than 0.1 for major molecule to be called major molecular response, less than 0.1 at 1 year. So these are the earlier that had kind of second generation TKIs, 3 months cytogenetics. Obviously, the earlier the molecular response, you get the better PFS, the earlier you control the disease. So this is a very important slide, which we should always consider before jumping to the conclusions. Where from we have done our RQ-PCR for BCR-ABL, because almost all your labs do it, and how many of them are actually standardized enough, participating in the international ecosystem, have the proper conversion factors. That is very important. What technology they use is nested PCR, is multiplex, or is it digital? Although digital is still the best, but the availability is still an issue. So I think before changing or reacting to any RQ-PCR, it should be properly repeated from a lab, which is at least participating in EQUAS program for doing this test. So this is what I said. We have warnings, we have failures, which is different at different point of time, 3 months, 6 months, 12 months, after 18 months. If you have stopped the drug, if you're then when you check. So I think this all of us know, or if we don't, we do check it at that point of time. So first line is after seeing the patient factors, your own choice, your own what you are comfortable with, comes the failure. And there's still 30 to 40%, which may need due to intolerance, due to not getting into MMR. So what are our choices? Obviously, you have to do a TKD mutation analysis at that point of time to decide your next choice. If there's a mutation, there are drug specific, which can act and which cannot act, like T351I. If there's something like that, there's no role of nilotinib, dasatinib. The only rescue is ponatinib. So once you have a warning or failure, you need to do TKD mutation analysis. And then this is the PFS with second generation TKIs after imatinib resistance. Not much of the difference between the three. So this gives bosutinib a chance in the second line therapy. So if we see this is the dasatinib after imatinib failure, the interesting thing is that 140 milligram per day is lower than 100. So we all know that lower dose dasatinib is the new normal. We see optimal doesn't always mean maximum. Most of the patients may tolerate 50 very well and achieve all the molecular targets that are required. So T351 is the scariest one, which we have, or more than 2 previous therapies. So in this, we have responses in which it has been compared to the other, like if it is imatinib resistant or imatinib intolerant, dasatinib resistant or nilotinib resistant tolerance, the various molecular responses like major cytogenetic, complete, partial. I don't think anybody will use anything else except the ponatinib in such patients, because so the good slide about this is, even if you have a T351I or if a CML TKI resistant, there's such a good amount of patients that may actually go into major molecular response or complete cytogenetic response. So this was optic approach. It was very good because we know ponatinib is very costly. The compassionate program doesn't enroll many patients. So this was dose de-escalation kind of. So if you give 45 milligram, achieve BCR-ABL less than 1%, and then go to 15 milligram per day, the response is quite good and is achieved. But those who went to 30 to 15 or 15, the responses were not ideal. So the ideal is to start with 45, achieve a BCR-ABL less than 1%, and then switch over to 15 milligrams. So this is the change in the BCR-ABL with the change in the dose. So if you see those with 45 to 15 are doing the best. The other drug on the block is semenib, the latest one, the STOMP inhibitor. It's still not available in India as a regular drug. It's still to be only available with a compassionate use. And it is effective in T315I, and many there's already a resistance to other more than one or two TKIs. That's what there's a criteria for providing it on a compassionate basis. So it's good that we have anything else other than ponatinib in such patients, because ponatinib, even patients do progress on with T315I, but till we actually get it in the country, the procurement and everything else is still a problem. So it's a comparison between bosutinib and asciminib. And if we see this, I mean, since bosutinib is available freely and so generic, so if we don't get asciminib, still there is a good amount of at least 20% of patients who still go into BCR-ABL of less than 1% with bosutinib. So we should always give a trial of bosutinib in those who fail your regular drugs. So this is the comparative efficacy of third line, as bosutinib as third line. You see, if you use bosutinib, they're almost same. Ponatinib is definitely higher chances, but bosutinib are same almost. Discontinuing. So I personally prefer we should do only in setting of a clinical trial, or if there's a patient who has like a female who wants to have plan a family or something like that. Other than that, the kind of laboratory support we have in except few metros is not the kind of monitoring that actually is required for DMR. And to MR 4.5, stable DMR, and then weekly monitoring, monthly monitoring. I don't know how many patients can afford outside of a clinical trial. Toxicity management, no drug is safe. So all of these TKIs have their own side effects. So imatinib, we all know edema, fluid retention, myalgias, and skin hyperpigmentation. Dasatinib is pleural pericardial effusion, there's bleeding risk. Bosutinib has GI side effects, rash. Nilotinib, pancreatic enzymes, and especially peripheral artery disease and cardiovascular diseases. Ponatinib is arterial hypertension, pancreatic enzyme increase. Asciminib is lipase, amylase elevation. All of them have myelosuppression, transaminitis, and dyselectrolytemia. So we see dasatinib fluid retention is quite common. Imatinib not so very common, although it is common, but especially pleural effusions and all is a problem with the dasatinib. And then this is how do we manage? I think all of us know cytopenias, and we wait, then we reintroduce, then we decrease the dose. And especially in anemia, we should give a trial of iron and B12 right before just we have more than 2/3 of females anemic because of the other reasons, other than giving contributing everything to the drug. Effusions, we all know, then imatinib fluid retention is there, anemia is there, joint pain. We obviously decrease the dose and see. So same here, if there's neutropenia less than 1,000, we were there, or then reintroduce the lower dose. If there is severe rash, we cannot use it again. Nilotinib rash is a problem. There's a lot of food interaction. And then cardiovascular disease, peripheral arterial disease, and absolute contraindication. And QT prolongations are there. Thank you.
Thank you, Dr. Reshma, for the wonderful discussion and presentation on the TKIs. We know sometimes it's very difficult to place a TKI, which TKI should be given or which should not be given to a patient. If the time allows, I have a case which I need to discuss with you.
Yeah, sure. Please go ahead.
I have a patient who was diagnosed with CML about nearly about 8 months, 6 months back, 8 months back, you can say. He was started on imatinib and the response was not optimal. So we switched to dasatinib. So initially he was on 50 milligram. We advised 200, but he continued with 50. Post first 3-month report, the IS units were on the falling trend, but he developed pleural effusion, which was about 1 liter. So we stopped it, we removed it, and then again we re-challenged him. But again, he developed a pleural effusion, so we didn't continue. He requires steroids and diuretics, and he was managed. Now we switch. We get the IRMA done, so IRMA was negative. So then we switched him to nilotinib. Now nilotinib, his amylase lipase levels are rising. So we stopped it and we started him on 150 milligrams.
So by suboptimal response, you mean like how much imatinib was he taking and what was the response like?
He was, if I'm not wrong, he was taking 400 milligram and there was a rise in, initially 3 months, there was a fall in BCR-ABL and then after 3 months, there was a rise. He does a lot of window shopping with the doctors too. Means he consulted.
So did you try to give imatinib 600?
We advised him, but at the same time, we advised him the dasatinib also as it was available as generic. So he opted for that. Now we are thinking to switch back to imatinib either 600 or 800 mg.
Yeah, so the option with you is either because he had tolerated imatinib.
Yeah.
So either to go back to 600 or get a compassion. If finances are not a problem, then ponatinib is an option. Is he an elderly like cardiovascular comorbidities or that is not a problem?
No, nothing. He's
so one of the options is either a ponatinib, start with 45, get it less than BCR-ABL of less than 1%, and then you can change it to 15 milligram. Or since he had tolerated imatinib well and had earlier had a response, then you can again go back to imatinib. But if BCR-ABL continues, I may repeat TKD because the regular TKD mutation analysis are not NGS based.
Yeah.
So if the mutation load is low, you may falsely have IRMA negative.
IRMA negative.
So if the BCR-ABL continuously increases, I would prefer to repeat a TKD mutation and maybe since asciminib is easily available on compassionate use, you just have to apply on their website. They will ask few questions and they usually give freely, not much of hassle. But till then, because it has to be imported and all, either you can shift him back to imatinib, see how he behaves. And Counts he did not develop cytopenias and all, right?
He didn't develop cytopenias.
Yeah,
Just
so that
so
that means marrow reserve is there because sometimes if you increase the patient up to the cytopenia, so you are kind of stuck. The BCR-ABL is there, but the cytopenias develop. So that's good. Either you can try him if analysis is not a problem. I would definitely go for ponatinib since the two other drugs he's not tolerating and have both times developed kind of side effect which kind of leads to the discontinuation rather than those modifications. He's already on 50. So I don't think is if you going to reduce it further, it is going to be much effective. And nilotinib, since he has developed transaminitis and other things, so I would prefer ponatinib. Start with 45, see how he behaves, and if he goes into BCR-ABL less than 1%, then switch it to 15. Or in the meantime, you can apply for asciminib to see like how he behaves with the ponatinib. Ponatinib also has a lot of side effects, but usually 15 milligram is manageable.
But asciminib also has a side effect of pancreatitis, no? Amylase lipase.
Yeah, frankly speaking, I have only 2 patients with whom I have got this drug free because of this. But at that point of time, you are just trying to give something because you are out of your options. Usually, I give it kind of to control the spleen size and I take them up for transplant. I have one patient with T351 progressing on ponatinib, and another one who had no marrow reserve. He was developing bad cytopenias even with 20 milligram of dasatinib. So asciminib also I couldn't give. So it was just trying and then taking up for transplant.
Okay, transplant is they are not responding, and now allogenic transplant.
Yeah. In fact, in your patient also, you should start seeing if HLA match is there and do the HLA matching with the sibling, because it's always better to take CML in CP.
Yeah, that's true.
Then to progression and blast crisis, and
Blast.
yeah. So if you have many warnings, many failures, if we see the data before imatinib, the CML transplant was the most successful transplant. So the role is still there. So you should in fact HLA type your patient and see if you can kind of, if he is 12/12 match, I mean, my threshold for transplant will be very low.
Correct. Thank you. If any other queries are there, then it's okay. Otherwise, we can switch to the next discussion.
Thank you.
Thank you, Dr. Reshma. Thanks for the time and wonderful presentation. So not wasting much time as we are already running behind. So about 30 minutes. So I welcome Dr. Kishore Kumar. He is a senior hemato-oncologist and bone marrow transplant physician at MIOT International, Chennai. So sir will speak on the oral therapies in AML. It's a really a hot topic nowadays, having oral LAZA and midostaurin. So over to you, sir.
Thank you, Dr. Uncle, and it has been quite nostalgic for me to get back into Punjab. I left Chandigarh in 2010.
Oh, we will love to. So once we have the physical meet, we'll definitely going to call you.
I would love to actually. So thank you for including me in this sessions, and it was quite interesting to listen to the previous speakers, especially their what to say, like the more experiences than theory. So anyway, we are short of time, and one more thing is I'm in between Saturday afternoon's non-vegetarian diet and this. So I won't take much time. It's a very short 10 minutes presentation.
Sure.
No drug I'm going to promote here. Even in Swiggy I ordered, it's my own food for that matter. We will get on to more scientific stuff. Right. So MBBS times, what I know about AML is like you start having oil rods on the slide. If at all the postgraduate has already written it on the slide or broken the slide at one point. If oil rods are seen, we call it as AML. And then things were quite easy, I suppose, when I started my even the residency. But I can divide it into two ways. Maybe a decade earlier, what I have been doing, and now what I am doing. So AML has been a long story. AML, aplastic anemias. For at least 2 decades, 3 decades, nothing changed. We were just following the Germans post World War II. They're very aggressive fellows, giving 7+3. A lot of changes were made to 7+3. They tried 10+7 or 2+5, except 6 and 9. They've tried everything, I should say, but nothing worked. I mean, AML at the end of the day, go to the CR database. The actual life expectancy of a patient diagnosed today after 3 years, even 3, not even 5, and 3 years is going to be not more than 20%. That's in spite of having all the clinical trials running in the country and with a good transport support also. But that bad a disease it was, and especially when the disease was affecting the older ones. When I say old, it is not like any age cutoff I'm going to give here, because India is a different country. Many times these are referral cases already kind of messed up for some time before, and then they get or come on to us in a tertiary referral center. So I still remember those times where low-dose RSC was really a nasty drug. We had to give something, so we used to give sometimes if the patients are quite good in taking insulin themselves at home, at least the family members, we would just ask them to carry on with this low-dose RSC. It was more like a palliation. It was more like booking your tickets to Kashi or Rameshwaram and nothing much to do about. But in those scenarios itself, one oral drug, which when we talk about the newer ones, we forgot the age-old drugs also. Hydra has been sometimes game changer, and even in CML today I have seen quite a good numbers not responding to anything, waiting for asciminib and then getting onto hydroxyurea back to continue their regular work. So in that way I can say things have really changed. More than things being changed, thanks to the researchers who are sitting in the laboratory to study the cells more and more in detail, because it's a liquid biopsy. And if you really look into oncology as a whole, most of the newer agents or what to say, the molecular signature understandings all come from hematology, just because the cell is something which is very, very easy to do research upon. So after a decade, I can see that the entire landscape is really changing. So it's not just IR which is important. We confirm it by flow, and it has been a routine practice for us. At one point, it was cytogenetics. Now we do want to run some PCRs just to make sure, at least to give an idea to the patient, because the ultimatum, sometimes we feel the transplant needs to be done. But at least to counsel them that way, or even give them a chance to CR2. So this kind of data becomes quite important, and it is becoming more and more confusing also, sometimes quite irritable also, because we get an NGS, some mutations which we haven't heard of, and patients Googles it and comes back to us asking about it. That sometimes becomes nasty. But still, in our personal, and most of us would be doing through this, the morphology, then flow, and conventional cytogenetics would have been sent in most cases. And last at least a decade, I should say, we have started having consistent samples for FLT3 or NPM, at least to do some basic standardization. Of late in the US, we have got IDH inhibitors, so they are starting to give importance to that also. So naturally, if the patient is not even affording these mutations, it's very much for sure that is not going to afford any further treatment. So if the treatment is not going to be in the pipeline, then no use of doing all those things. But at least if you want to do and put up a data, a local data collection, then I think this is a minimum set of investigations which we have to get on. So now, after a decade of practice, I can say that not all AMLs are same. There are a lot of biological variables like the in-depth mutation studies, and the other end is financial variables, the place where we practice, and indeed quite a lot associated with the patient side also, like logistics, the finances, how much they spend. All this are to be taken into consideration when AML treatment is going to be done. But when I talk about oral therapy, many times we tend to forget this, because this is one disease which has got an excellent prognosis. And the moment we all know that, even indeed we suspect, with the limited knowledge what we have on a slide, if we, even I suspect an APML, the first drug I'm going to give you before waiting for all the results to come is ATRA. I should really thank the Chinese. There is a long story, very interesting story to read about ATRA, and even a part of India also, where ATO was studied extensively. So in one way, one of the earliest and still a wonderful drug that works in acute promyelocytic leukemias, we really got away with chemotherapy. This is a beautiful example of understanding the pathophysiology and trying to target something. So these are all age-old stories. Now we will just come to what are we doing right now. So especially after 14, I think 2013, 14. Before that also the hypomethylating agents were available, but unfortunately I still remember the CMC days where we will be waiting for importing the drug, like what we do venetoclax software. But later it was initially all about myelodysplastic syndrome, and people started understanding better, and they slowly pushed these drugs into the frontline AML treatment also. So I think this is what most of us are doing. Fitness is really assessed by the clinician at that point. We have got even very younger patients sometimes, bad pneumonia, fungus. He won't be that fit enough for a 7+3, in spite of the fact that his age may be okay. Those conditions also we try to sometimes start with hypomethylating agents, put a hold on the growing leukemia, get the patient out of regular, what to say, like the toxicity, and then get back to a consolidation with 7+3 or high. But coming to, I will try to discuss the newer oral agents through some case-based discussions itself. Here I got a relatively younger individual, because I am 39, so I keep on increasing the age, how to call somebody as young. So he is a guy who had higher TLC, around 87,000 TLC, low platelets, and bone marrow aspirate was jam-packed with blast. And as we expect, younger fellow, very high TLC, there is very much was a possibility that the FLT3 ITD is going to come positive, not in all cases. So this is quite significant. What I would have done before, I would have done some changes to my doxorubicin or daunorubicin doses to 90 per meter square, or I would have put into a double 7+3 consolidation, and then get them for a transplant as early as possible. That's what we have been doing. But maybe last, I think 5 or 6 years, I suppose, I think 5 years. So this drug started coming in because we did a lot of study on FLT3, and all this time, there's a basic ideology behind all these things. Let it be imatinib, bosutinib, what else. Any IMPs are going to be more of tyrosine kinase inhibitor function. They have a tyrosine kinase inhibitor function. Mitostatin, in one way, though it is a bit different to the rest of the thing, I should say it's also a part and parcel of doing something like that. But genuine concern practicing in India is whenever some 7+3 itself is quite toxic. During my government days, I should say, many may not be accepting it overtly, but induction toxic mortality in some centers where the facilities were not there, the cases are just loading in. It went up to 30-35%. So that's a poor state of affairs with the gram-negative MDR, gram-negative bugs what we have got in our. Sometimes I feel transplant is much easier than an AML induction. So in those cases, we almost always start worrying to add on any another drug which may worsen the cytopenia, because our data, the Western data is entirely different. They don't. I still remember the UK days where even aplastic was getting maintained with the TLC of 300, 400 for 3 to 4 months. That is something which is unimaginable in our country with the present scenario of multi-drug resistant organisms we have got. So this hesitation is almost always there for people, especially the treating clinician. Should they really add up a new drug to the already toxic regimen? But I personally feel we indeed had a lot of data points studied, and this was one of our presentations. I think this was in 2019, the data to 2019, where we looked into the FLT3 prevalence and outcomes in our population. So it was around 20 to 24%. I think it is in lines with most of the data from India as well as from abroad. So at least 1/4 of the patients may have, especially the younger ones, when they're coming with high TLC, they may have this FLT3 ITD. And one more thing I want to say here is NGS, somehow NGS is like more of point mutation detection. So if I'm going to totally rely on NGS platform alone, it is very much a possibility that I may be missing the ITD mutations of FLT3. So I still prefer ask my junior colleagues to get on with the regular PCS and then send a sample for NGS, nothing wrong in that, just to make sure we are not letting out this FLT3 ITD go away unnoticed. So this was a ratified trial, quite a well discussed trial over the last 3-4 years, where they started midostaurin immediately the day after 7+3 was getting over, and they were trying to continue it for every cycle. And first time they started introducing a concept of maintenance, I should say. ALL, we all know about metronomic maintenance, but AML, nothing much there was. I remember my residency days using 6TG. There are some German protocols doing that, but it was all like a formality, nothing worked. But I think this drug opened up a new way of looking at ALL, where even the patients are not fit enough due to multiple reasons for a transplant. There was a possibility to continue the drug as a maintenance up to a year. So as we see here, these are the red dotted lines, which are FLT3 patients who go on to get a transplant. Definitely transplant in these cases provides relatively better long-term survival. But if you're going to add up your midostaurin in the, what to say, like achieving a CR1 along with 7+3 chemotherapy or early phase HIDAC chemotherapy, definitely the overall outcomes were better, and provided you are going to consolidate with the bone marrow transplant. So as a bridge to transplant, reducing toxicity, reducing actual the FLT3 ITD's allelic ratio, it does mean a bit. So midostaurin now off late, I think generics are also available. So I think that's a good try to give. But one other oral drug which we have been giving for years is sorafenib, though mechanism of action may be a bit different in solid organ malignancies. But FLT3, nothing was available. Sorry. Sorry for that. So FLT3 was kind of, even before FLT3 patients, sorafenib was one drug we learned from our hepatology colleagues, I should say. But somehow, not only theoretically, practically also we have seen it's very, I mean, not a big game changer, I should say. It's more of a non-specific drug and had a lot of side effects in few patients, had foot syndrome and all those stuff. But of late, you have got midostaurin as well as gilteritinib, both are FDA approved. Especially the second drug has got its approval as a part and parcel of CR2 as well as post-transplant maintenance also. So that way, FLT3 is kind of taken care of, but I will still feel that transplant discussion should be done right from the start, and we have to kind of, our aim almost always in a fit patient is to consolidate with the bone marrow transplant. So now I'll come to a really old patient who is not that fit enough to undergo all these things. I'm going to depend upon some medications. A very elderly gentleman again with AML, and in the background I can see some myelodysplasia going on. So other things, no mutations, nothing got positive. So I think this AML 001 study was one big game changer, where most of these older patients were put into the train ticket or flight ticket to Kashi or Rameshwaram. They suddenly switched over. We were starting to look at them in a more better quality of life. I'm not sure how much quantity of life does it make a difference, but at least in 30 to 40% patients, when I'm starting them on azacitidine, and India cutoff keeps on changing. As I said, it is not like above 60, above 70, nothing of that sort. You have to clinically, your clinical acumen and judgment is what is going to happen. I still remember using patients in a palliative mode in CR2, since relapse cases also, sometimes they're going into remission. So such a beautiful drug really has made our life easier, especially treating the elderly patients. But theoretically, it gave a median survival advantage, which I think in a good proportion was getting reflected. But the practical reality is, in spite of the fact that I'm saying azacitidine to them, there's very much a possibility that I may say to them the response rates may not be more than 30 to 40% in our setting, and it's very much possible you may be losing your response offline. At the time, I had nothing. I can switch out to decitabine, but decitabine and azacitidine are just chemically kind of have got a lot of crossover. So we really don't know the actual pharmacokinetics of the both in our patients. But suddenly, I was listening to Dr. Jain also, who was very enthusiastic about venetoclax. And now I can say in Tamil, we call it a Sarvaloga Nivarani, so anything that works in every case. I think any hematologic, at one point, my professor used to say, none of your patients should, and in general, none of the patients should leave the world without receiving steroids. Now I can say none of these hematological patients won't be pulled out into palliative care without getting this drug, venetoclax. That much is the penetration. As students of science, sometimes we really wonder that drug was introduced for BCL2, CLL, lymphoma, and why the hell it is working in AML. But we are in that, what to say, helpless state that we are happy with any additional thing which kind of gives a better quality of life and simultaneously giving a better remission rates also. So this is a Viale A trial where they actually started this drug venetoclax along with azacitidine. The protocol was going up to 400 mg, which all of us know that it is quite toxic in our country, financially as well as side effects. So what we generally do is get on with 100 mg of venetoclax along with posaconazole, making use of the form of second year pharmacology, what we are read in MBBS, just to increase the drug levels. And that seems to be kind of working. So it's not, initially we were very skeptical about adding newer agents. We don't want those cytopenias, nasty cytopenias, and otherwise older individuals. But I mean, after a lot of push and this thing, a lot of discussions, now most of us have started at least adding venetoclax at a lower dose of 100. That one main thing is this study, Viale study, where if you look at the CR rates with the azacitidine and venetoclax combination, this is at least 3 times of what a placebo can do with azacitidine. And the beauty of this drug is the CR and CRI by the start of second cycle itself. That is, azacitidine, when I talk to them in a single agent, I say you have to wait for at least 6 months. In this 6 months, you may need transfusion. Sometimes blast may be roaming in the circulation, but I'm just giving it so that you are not fit enough to go in with the 7+3. But looking at this data, I think I'm not sure how much we can replicate. Our own data can't be published since we don't have the drug right now in our country. But still, looking at this is very interesting. Adding up an oral agent is going to increase the CR rate in second cycle itself, at the start of second cycle itself, at least 4 to 5 folds compared to azacitidine alone. So I think data looks quite good. Maybe unless we drive down our own data, the practical implications, we have to still wait. But people have started using it a lot. Not only that, it was giving a good remission rates. Naturally, it was reflecting in the median overall survival also, which we know with the AML-001 itself, azacitidine alone can give a median survival of at least 10 months. Addition of this drugs was actually pushing it to another 4 to 5 months, which I think with the desperation in AML, this is something to be talked about. 2 drugs, these are the drugs which are available in our country, even available in different formulations. Sometimes generics, mitostatin is also available. IDH 1 and 2, yes, people have been talking about it. Big, I should say, the Indian mafia in America, that take care of what was it, myeloma and AML part. Sangeeta from this part of the country, she's one of the lead researchers in doing this IDH mutations on the drugs to IDH. But there are 2 drugs, unfortunately, none of I'm no, at least I don't have a personal experience of using this drug. But data seems okay. Now only we have started capturing IDH mutations via the NGS results, what we are getting. So these are also some drugs which may be kind of useful to us in the long run. One thing I just forgot to say in the Viale study is, as you see here, across all the mutation groups, so instead of having a IDH 1 or 2, instead of having FLT3, the venetoclax addition was working in most of them. So is it going to replicate it in our patient? I'm not sure about that point. But this is, as I said, a Sarvaloga Nivarani. It is very much possible that we don't have to much bother about sometimes the NGS results also, because the patient is already 70. So getting on with this drug may be useful. They say till progression, venetoclax, but I personally feel 3 to 4 months, get a good remission, and then start thinking about doing something else to the patient, either consolidate with a transplant or get on with some kind of a maintenance. So this is also a very old drug, to be more frank, though the presentation is from 2020 and the FDA approval came recently. But actually, this along with IV azacitidine, this has come up in a big way. And the data, if you really go and Google the data, there are data from 2003 and 4 itself. But somehow it got its oral azacitidine has got its approval, especially in the maintenance phase for people who are kind of elderly. So this was one thing, because we all, whenever I say to the patient, I say that I've given you 4 cycles, 5 cycles of chemotherapy, you have got a good risk or you don't have a donor, so I'm not consolidating with the transplant. when he's going to ask me what are the chances that I may get the disease back, I just say to them that up to 3 years or even 5 years not getting over, it is very much a possibility that your drug disease can come back. So in that scenario, patient commonly will be asking something, are you going to stop all the drugs to me, or you want to give something? Should I be taking something to prevent the relapses? So this concept of maintenance wasn't there. Myostatin started it. Now azacitidine has got an approval, especially in the post-CR maintenance as a oral formulation, which is much useful for the patient. But there are a lot of issues with that also. These patients, the cost is no cheaper. Sometimes insurance companies are not reimbursing it. So there are a lot of patients, in spite of achieving remission, they still are having an intravenous formulation of azacitidine or even a subcutaneous just to get their insurance reimbursed. So that's how I mix and match. But if you really ask me, 6 months, 8 months down the line, if I achieve a decent MRD, not even a very stringent MRD, because MRD standardization, like Madam was talking about IS standardization, MRD standardization is also not something which is great about when it comes to AML. We are just learning more, simple. So that way, yes, this drug has come up maybe last 6 months or so. Most of them we are yet to start. We have 1 or 2 patients on it, but I'm not having a big personal experience on using it in the maintenance phase, because most of the patients eligible, we try to get on with the transplant. But one beauty of this drug is there are a lot of data, old paper from 2019, which talks about post-transplant maintenance also. We have been using azacitidine in post-transplant maintenance, especially when the graft is kind of going away. I think oral AZA also has got papers to support it, and in few years from now, there will be a good amount of data to suggest instead of having a transplant, we may be continuing with oral azacitidine. So that was quite, these are the drugs which are available in our country except for IDH 1 and 2. But if you really look into this disease in the last decade, a lot of things are happening. There are intracellular targets, there are extracellular targets. So at this point, theoretically, people say that there are at least 20 drugs which are in the pipeline. And if you're good in mathematics, do a permutation combination, that's quite a good number of doublet and triplet combinations which is possible in the near future. So this is going to get messed up. We may have to read more. Patients are going to ask a lot of questions, and it's better that we keep ourselves look like at least more educated in front of the patients who have Google in their hands. So that way, things are really happening. A disease once was like putting patients into palliative care, a very bad prognostic disease, high induction mortality disease. I think these newer agents, not only the oral agents, there are a lot of things like the liposomal 7+3, I mean, which is coming up for the elderly people, which we don't have right now in our country. So things are changing a lot. Maybe this meeting happening after a decade later, it is very much possible that most of my AML patients will be just on OP based treatment, like what we do for myelomas or even CLLs for that matter today. So that's, things are changing for good. And thank you very much, Ankur, for giving me this opportunity.
Thank you, sir, for the nice presentation and really lovely and interactive session which you have given. With your presentation, it seems that the AML treatment is going to change and it's very easy. But
hope so.
Hope so, sir. Sir, if I have a question, like if the patient is not going for the high dose therapies, most of the patients they don't opt for it. Means those who are 50, 55 plus, sometimes we are also hindering ki if we're giving 7+3, we may lose them. Instead of giving them 2 years another, we may give them just 1 month. So the patients who are on AZA or who are on decitabine and post 3 months or 4 months or 5 months, they are in remission. So will you consider them as CR? I have a patient who is FLT3 positive. AZA plus Mido is going on.
Understood.
4 months down, the FLT3 is negative. We didn't do the marrow, transfusion independent, nothing, just 7 days AZA and Mido daily. That's all.
Understood, Ankur. Ankur, actually, before this oral thing coming up, what we used to generally do, even CMC practice is the same. Most of the time for the first year, in spite of a good remissions, 6 to 9 months is going to be a monthly therapy. I start discussing with the patient, giving a small leverage, saying that I'll do a marrow sometimes just for patient satisfaction, that I'm going to reduce my frequency. We generally do it for 6 weeks once, and Professor Biju almost always used to say, second year go for 2 monthly and third year go for 3 monthly once. This is very, very anecdotal, and I mean, we worry a lot stopping it. Actually, we have bad experiences where 6 months, excellent response on azacitidine, MRD was proven negative, was cured for a transplant. 61, the daughter had to come all the way, I mean, the brother had to come all the way from US. That waiting period, within 2 months, I was seeing the blast coming in front of me like a ball which has been thrown on a wall. So this is like definitely good. One way what I can say is the quality of life remains good for these patients. I'm really not sure about the exact overall survival benefit. But of late, though we haven't done, people are thinking about oral AZA maintenance, but doses and how far the compliance is going to be there. That's all a big issue, I suppose. But reduced frequency of azacitidine when we go to the second year, third year is something which is doable. And many times these MDS really patients, they don't get into full remission also. Even peripheral blood will be showing some monocytes and this thing. But they just carry on. I want them not to be in hospital. That's all. I'm killing them with the sepsis rather than getting on with the stringency.
Yes. True, sir. That is what her daughter used to ask me every time. She stays in UK and she's the only daughter they have. So
Sometimes relatively fitter, just to put an end date to it. Earlier days we used to even do HIDAC at a very, very low dose, not HIDAC, I should say, maybe 1.5 for 4 doses or 1.5 for 6 doses, just to say to them that we are putting an end to therapy. That sometimes is nagging for them. They feel they're okay. Either ask them to go on the transplant. But if they want, okay, not okay. Many times it's elderly, the donors are also quite elder, and haplo in elderly is also something which we take a very, what to say, informed decision. We have got burnt our fingers in the early years. So that way, sometimes HIDAC in the sense, some degree of consolidation can help, and then put them on some maintenance. This we have done in few, I should say. But actually coming to that level, this is again, it's a very gray zone area. To be more frank.
Yeah.
So it's very individualized, and we have to take patients' concern also before doing that.
Sir, and regarding van resistance, have you seen any patient who is resistant to venetoclax, or are there any tools or laboratory investigations which?
I don't think the problem is that we don't have it right now on an official basis, and we all know that though Indian companies may be making it, we get it through multiple, and our data can be published. Somehow, when levels and all ideally should be done. If you ask me that, do you really titrate it up? I have not done it. If there's a decent response, I just leave it at that point. Sometimes we use when at a very bad choosy of patients also in CR2, like they already got into a relapse. We try to use it there, but I somehow, with the limited experience what I have, it was not the same like how we are going to go in CR1. We were very, very what to say, like thinking a lot about starting this drug maybe in a year or two before, because a lot of data came in, but it was sometimes it sounds quite unscientific also. Why does it work in AMO? But off late, since availability has also come in a cheaper way, it's like I'm suggesting it's at the end of the patient. He has to continue. Sometimes we have these patients buying in lakhs, and the patient dies in a sepsis, and sometimes we get into this problem of what to do with the drug also. So all these are practical issues, but I clearly say whatever I do, 3 year, 4 year survival rate is not more than 30 or 40%. That itself is more optimistic on my side. So they understand that is fine, I suppose.
Dr. Mukesh, any question from your side?
Thank you so much, sir. Always wonderful to listen to you. So what's the maximum dose of when you have used?
Actually, Mukesh, like with the posaconazole starting up, I think we are not going beyond 100 at this point in time, along with posaconazole. CLL, we did wanted to try or see what happens. So maximum we have gone up to 200. That too was very shortly. The cytopenia is something worrying. It may not be actually after some time, but our patients, we don't want to lose them. I mean, we don't want even admissions also. We keep them on a very, very tight follow. Every week they send a CBC to us. We have seen going down to 800. But the data says if you are able to continue somehow this venetoclax for 3 or 4 months, it is very much possible that a response seems to be a bit better to azacitidine now. I can't say it's a magical drug, but seems to be working in combination. And maybe later we may even continue oral azacitidine venetoclax as a maintenance therapy. This is very what to say, we have to do to be more frank. Their data may be different, so it all patient to patient basis. When, to be more frank, sometimes we are quite worried also because it's not a DGC approved thing at this point in time. So we don't push much actually. We write and give it to them. Sometimes we just start on azacitidine. I'm frankly saying it to you. Some response not so great, then I would have every research summary will carry a fact saying that if there is inappropriate response, we may add venetoclax at a later date. But we have done in a few, and it even works at that stage also. People who are not achieved a remission and then getting back, I'm not sure. I mean, the relapse setting, it's a death sentence many times.
Yeah.
Right. So your take on subleukemic AML patients for the usage of venetoclax. So I have one patient treated by some oncologist. So we did after 1 month of therapy with AZA plus venetoclax. His counts were baseline again low, some less than 2000, but now he's going somewhere around 800. Okay. So we did the marrow is in remission. So we started with the second cycle. So what's your take call on using addition of venetoclax with such a low count? But now his platelets have improved 2 lakh. Initially it was pancytopenia. Platelets have improved, and he is now transfusion independent. But TLC is still in the range of around 1000, 1200 and neutropenic. Though neutrophil count has increased from like less than 10% to 30%. We started with second cycle of ESA. So when to add venetoclax, we have withheld for the time being.
I think if symptomatically, as I'm able to understand that patient performance status is relatively okay, I suppose. So
yeah, he's around 60, 65. Performance status is good.
So I think 100 men, but try continuing. So if he gets into an admission with a pneumonia or something, just call it off and continue with the azacitidine. That's what we do, actually speaking. Please say to them multiple times, this may push you down, push your counts down, needing unnecessary. But if you really ask me, if many times my target is to at least use it for 3 months. In spite of the fact that if it is really not toxic, patient is not getting into ICU or pneumonia, I just try push so that that's what the data looks like. If you have started it, otherwise don't start it only. If you have started it, okay,
yeah, right. So our plan was like, if okay, disease is still there, then definitely you have to continue. But if disease is not there, because he was having intermittent fever with the transfusions, but not like in sepsis. But so kind of for the timing we have with that, we'll get started.
Last year, ASCO, if I'm right, there is data coming up in MDS also, not even a full blown. Naturally, when we can't sell the drug, we sell the disease. So they have started doing everywhere. So I think one way answer through the MDS part, I suppose if we can use it in MDS, it means that okay, chalo, cytopenia is also fine. But we need a tight monitoring, because this medical legally also sometimes we are quite worried that don't want to get into quite litigious.
Yeah, right.
You continue for 28 days.
Yeah, let it come. We have been asking every company to do that. So once it comes, our experience will be much better. And we are not allowed to publish. That's a problem. People are using it. Maybe unless it is not available in India, publishing it may be a problem, actually.
Yeah, exactly.
So you
oral azacitidine. Sorry. Yeah, go ahead.
We keep on saying to patients, but most of them are insurance covered. So they will say that this insurance company is not allowing me to take oral drugs. I will get admitted for a day, put me IV injection, IV even. I give it a subcutaneous, but at least for insurance purpose, I put it as IV azacitidine, take bulk purchase 6, and then they come as daycare or whatever. So maybe because of this reason, somehow oral aza, in spite of the fact that looks quite interesting, we haven't used. But ulta, what we have done is sometimes in very, very elderly who are not even able to come to hospital, we do give them this option of oral azacitidine, but they are poor masters to start with. So with that, it's very tough. Frontline doesn't have an approval, and with the small data, it's very at this point it's very tough to say that can we switch over totally a oral therapy like what we do in other some malignancies. So, but I think more and more data coming in. This is what my personal opinion is. The day I started my career to now, for the elderly group, the quality of life seems great. Sometimes it gives 1 or 2 years, but the 1 or 2 years is more than enough for marrying their daughter or writing a will. This job is done at least. Olden days, it was pathetic that the death, how they go towards death was very pathetic at one point in time. That it has changed, I can say. Overall survival, I don't know.
So you are continuing venetoclax for 14 days or 28 days or 21 days?
MG, we are continuing for 28 days, but there are dose modifications in MDS, especially some say 7 days, some 14 days, because as Mukesh was rightly saying, cytopenia, we are quite worried. So maybe that's the reason they want to shorten it till give the benefit. But at this point, if tolerating, I'm continuing it, that's all, with the prosoconazole.
Thanks.
So this NH, we have this practice in during 7-3, cytarabine of 100 mg per meter square and HIDEC of 2 gram per meter square. Most of the centers still using this 3 and 200 in this inductions. What's your call on that?
Yeah,
we are seeing very good results with these doses also.
I mean, initial days in fifth standard, what we used to do was to stubbornly go on for 2 inductions, even to call them as refractory. Our bone marrow itself was after second induction we used to do, because like first induction, I don't know what I'm going to do with the patient. I had limited options at that time. So of late, okay, we are doing allelic ratios, etc., etc. Now things are much clear, at least to talk to the patient. Olden days it was confusing, but 7+3, yes, it has done wonders for a few, I should say. But from as a doctor, it gives a nightmare for us. But still, younger patients, we don't, unless there are specific targets, it's very, very tough that we are going to move away from it. It's a standard of care, and it's better that we stick to it and at least avoid medical legal issues to stick to it in the original Sampras therapy category. But drug 60 mg per meter square, and I think 100 twice a day is the maximum what I've been giving, or put it as a 24-hour infusion. That's what we do. IDAC, really, we have come down on the doses because sometimes the patient is really good. The last cycle he gets into a sepsis, and we feel so bad that we are drug toxicity. So sometimes even 1.5 to 2, 3 continuous days BD is what we are giving, and we are seeing that relatively the cytopenia window is not that bad. So it's all patient to patient base. I remember days giving 5 grams theoretically and burning our fingers. So once we practice more and more, we become a bit philosophical also. So
True, sir. True, sir.
Thank you, Uncle. That was a great meeting, I suppose. Here all the
Thank you so much, sir. Thank you, sir. Thanks a lot, sir. So if you allow, sir, then we can end the session and then we can end the meeting. So I'll not keep much in between your lunch and the things as you said, sir. So thank you, everybody, and thank you, colleagues. A big applause to all the learned faculty who has presented today and yesterday. I just a brief review that I thank Dr. Ravikant Porwal, who has presented on invasive fungal infections in hematological malignancies, and Dr. Mubin Mittal, who has presented the deep and the durable responses as a frontline myeloma, who has presented the latest trials for the daratumumab as first line, and Dr. Charu, who has given us an insight regarding the NGS testing in AML, and Dr. Pavan, who has given us a wide view regarding the right venous access and ATG in aplastic anemia, then followed by Dr. Reena Nair, who chaired the session for follicular lymphomas, where we have a wide discussion regarding the follicular lymphoma and the treatment options and when to start or when not to start. Not least Dr. Rajiv Gupta for the DLBCL as the frontline options. Then Dr. Ankur Jain, who has given the EHA updates in CLL management and given us the insights where we can use the oral therapies and what are the high risk factors in which we have to use or in which we are not used to use. Dr. Mukesh Chawla, who has given regarding the Jakavi updates in myelofibrosis to use early to have good responses. And then Dr. Reshma, who has given the use of TKs in CML. And at the last, Dr. Kishore has given a wonderful talk on oral therapies in AML. Thank you, everybody. And at the end, I would like to thank the pharma colleagues also who has helped us to make the meeting successful, and our academic partners and all the delegates and faculties who have joined. Thanks a lot. And thank you, everyone. Thank you, sir. Thanks a lot, sir.
Thank you, everyone, for
Thank you,
joining.
Doctor.
Good afternoon. Good afternoon.